Yeah, great. Richa, please take over.
Okay, I will start. Okay. A very good evening, everybody, and welcome to the FOGSI ICOG online certificate course, which is on MTP, abortions and litigations, a must for every doctor. So this is a 3-day course, and yesterday we started. So 27th, 28th, and 29th, it is a 4-hour course, and we have a pre-test and the post-test evaluation. And for this, I am very much thankful to our FOGSI President, Dr. Rishikesh Pai sir, Dr. Madhuri Patel Madam, who is the Secretary General, and ICOG Chairperson, Dr. Lakshmi Shikhande Madam, for her initiative, and Dr. Parag Biniwala. And I'm also thankful to the series convener, Dr. Charmila Ayu, and the co-conveners, Dr. Ranjana Khanna Madam and Dr. Sheila Mani. Okay, so now I'll introduce Dr. Lakshmi Shikhande Madam. She is the current chairperson ICOG, and she's also the national corresponding editor Jogi, and she is the national corresponding secretary Association of Medical Women India. So
thank you.
Welcome you, madam.
Yeah, thank you so much, Richa. And I'm so happy that as a course convener, you have come out with this very, very practical module with all the learned speakers and who are doing full justice to this 3-day course. So friends, today is the day 2 of this FOGSI ICOG online course. Yesterday, it was a great day. We had more than 600 doctors who logged in and attended. And today also, I'm sure we will have the same attendance, because for certification, you have to be present for all the 3 days. Again, I am seeing many queries in the chat box. Friends, we can't post yesterday's pre-test and post-test today. It is specific to that particular day. And once pre-test link has lapsed, we just can't post that link again. So just be alert and attentive. Don't give so much attention to the pre-test. It is just a self-evaluation. Listen to all the talks very, very carefully, because post-test is what is important. And there also you just have to score only 50% marks. So this is all. We will be telling you the rules and regulations repeatedly. On behalf of ICOG, I would like to welcome you all, delegates, our experts, our chairpersons, and of course, our convener, Dr. Richa Sharma, who has taken great pains for this 3-day ICOG online course. So without wasting much time, I hand over back to Dr. Richa for further proceedings. Happy learning to we all.
Thank you so much, ma'am. So now I will just give a brief revision of the yesterday's course. So yesterday was the day 1, and wherein we had touched upon the laws and the abortions. So we had given a brief introduction about the MTP Act amendments, then PCPNDT Act, FOXO Act, and the various drug protocols required for medical termination of pregnancy. Then also pre-MTP and post-MTP counseling aspect was also discussed, and also the how to do the MTP in the high-risk pregnancies was also described. And the most important thing which was discussed yesterday was the documentation and the paperwork, because this is very, very important, because MTP, although it is a very small procedure, it is governed by the Act. So we have to know each and everything about it, and we have to keep the paperwork and documentation in place, because now there will be a 1 year of imprisonment and fine also. So we have to be very careful. So that we had discussed yesterday. Then how to get your centers approved for MTP also we got discussed yesterday. And I'm happy to share that there were more than 500 attendees were there till the end, and lots of queries were solved yesterday. And today also we are looking forward, and today we will be focusing on the abortion part. And this will be including the various types of abortions, including ectopic pregnancy, cervical pregnancy, tubal pregnancy, then cesarean scar pregnancy, and also we'll be discussing about the molar pregnancy. Now, most important topic also which we are going to discuss is the consent part, because a lot of queries and dilemmas are there in the consent, especially in the high special category of the women, like if they are minors or if they are visually challenged women. So how to go about taking a legal consent also will be discussed today. And I am very privileged that today we have a lot of eminent faculties again, chairpersons and speakers who will enlighten you all with their knowledge. So now I hand over to Dr. Kruti for carrying out the pre-test. So pre-test will be just 10 minutes you will be given. We will keep silence for 10 minutes and you have to answer the questions. The link will be there in the chat box. And after that, we will start the scientific session. There are 30 multiple choice questions in the pre-test. So Nilima, can you please post the link in the chat box?
Yes, ma'am.
मिताली टाइमर ऑन करो प्लीज.
Those participants who have joined late, we are having the pre-test now, so we are keeping silence for that. And there are 5.5 minutes more for the pre-test, and then we will start the scientific session. Now 2 more minutes are left for pre-test. Last 10 seconds are left now. Okay, so time is up now. So we have finished with pre-test. And at the end of the session, we will have the discussion of all the topics. And then we will have the post-test. And at that time, we will show you the answers of each MCQs. So now we proceed on to our scientific session now. Okay, so now I invite the chairpersons of today's session. First chairperson is Dr. Ashwini Balarao Gandhi. She is the consultant gynecologist, PD Hinduja Hospital, Mumbai, India. We welcome you, Dr. Ashwini. Then next chairperson is Dr. Harish Doshi, sir. He is the professor and HOD of Obs and Gynae at GCS Medical College, Ahmedabad, Gujarat. And he is the past president of Ahmedabad, SOGOG, and also the Practical Ops Committee, FOGSI. We welcome you, sir. Our next chairperson is Dr. Aarti Chitkara. She is from All India Institute of Medical Sciences, Delhi, and an active member of YTP committee. Next chairperson is Dr. Sangeeta Raman Jogi. She is the professor and head Department of Obs and Gynae at Government Medical College, Bilaspur. So we welcome you, Dr. Sangeeta. So our first speaker is Dr. Archana Baser. She will be speaking on ultrasound criteria of viable and non-viable pregnancy. So now I request our chairperson to introduce Dr. Archana Baser.
You can.
Okay, so Dr. Archana Baser, she was the past vice president and she was also the past fellow representative of AICC RCOG West Zone and also the chairperson of Imaging Committee, CEFOG and AOFOG. So we welcome you, Dr. Archana, and she's also currently the consultant and the director at Akash Hospital, Indore. So we welcome you for your deliberations.
Yes, you stop your screen.
Yeah.
Yes, Archana, welcome. Are you here with us? Yes, welcome.
Yes.
Meantime, she is sharing her screen. Again, I am seeing many queries in the chat box. As I already said, the pre-test and post-link are day specific. We just can't share yesterday's pre-test and post-test link today. And for today also, we have completed our pre-test. So now you will have to focus on the lectures which are going on. And after all the lectures are over, we will be posting the link for post-test. Yes, Dr. Archana. Please unmute yourself. Yeah, Dr. Sumati, you can write to ICOG office and the staff will look into it. Vitali, Dr. Archana को co-host किया?
Archana, you are not mute. You are muted. Unmute yourself.
Archana, can you hear us? We are waiting for you to start your talk. If she is having any problem, Richa, you can invite the other speaker. Because I think she is not listening to us. Yeah.
Hello. I think move on to the next.
Archana, yes, now she is unmuted. Archana, are you ready?
Yeah.
I think I've registered and joined, but I can't see you guys.
We can see you.
We can see you. We can see you, Archana.
We can hear you.
Can you see my screen?
No. There is a share screen in the lower part.
She knows she is very much tech savvy.
I think there is some mix up.
So Archana, meantime, can we start with another speaker?
Okay.
Yeah.
Okay, you can start with another one because something has went wrong. I was. Yeah. Can you can see me now?
Yeah. No, this is your screen. No, this is Dr.
No, this is my screen. So
can this is not your screen.
Speaker?
Yeah, please.
Okay.
Teacher, yes.
So, so we invite the another speaker, Dr. Pooja Lodha. She is one of the.
So shall I stop sharing the screen?
Yeah. Please, you are not.
Archana, screen is there.
Archana, we can see. Yeah. Please start. Archana, we can see your screen.
See ma'am's screen.
Yeah. Now you can't see Archana. Where is she? एक बार slide move हो रही क्या देख लो अर्चना?
Yeah. It's fine.
No, but I can't. Yeah. So can I start, dear?
Yes, please.
Yes.
I'm sorry. I think I opened it twice, the Zoom. So it was getting confused. Anyways, so thank you very much, ICOG, for giving me the opportunity to interact with you all. And the topic which is being given to me is a very, very important and a basic topic, which is very important to be understood. That is ultrasound criteria for viable and non-viable pregnancy. I think today's generation is very lucky to be born in the era of ultrasonography. I'm sure my friends, Dr. Lakshmi and all who are my contemporary would remember that when we were used to be PGs, women would be there in the wards lying with just a pregnancy test positive, not sure whether the pregnancy is going to be resulting into a healthy baby or it's going to end up in miscarriage. So I think it is very, very important to learn how to do an early pregnancy scan. And my content of my talk is when to do an early pregnancy scan, development of embryo, finding on a normal first trimester ultrasound, can we predict miscarriage, signs of impending miscarriage, diagnosis of miscarriage, and safety of Dopplers in first trimester if the time allows, and if there is some other speaker talking on it, so please tell me, I will not take that into my talk. So we know that a gestational sac can be seen on transvaginal ultrasound as early as 4.5 weeks. The best time to do a viability scan is after 6 weeks, as it allows all parameters to be assessed. What is the happen as soon as the pregnancy test is positive? These days, women will come, do my scan because I want to announce that I'm pregnant. What you have to see that you have to calculate from LMP and tell them in advance that, look, we will do a scan, but we may not be able to see a fetal heart or a embryo. So don't get disheartened, or maybe you can defer the ultrasonography first at 6 weeks. Now, what type of sonography to be done, which way to do, whether transvaginal or transabdominal ultrasound. Now, various studies have demonstrated its multiple advantages of transvaginal sonography. By transvaginal sonography, detection of pregnancy can be at an earlier gestational age. There's an increased detection rate of ectopic pregnancy, better detection of signs of impending failure of pregnancy, and detection rate of subchorionic bleeds, blebs, and retroplacental hematoma is higher in transvaginal scan as compared to transabdominal scan. And there's no need for uncomfortably full bladder. It is time saving and visualization is better. So it is very important to know what appears when. I mean, if you are a beginner doing sonography and it is at times difficult to remember, then this is a very small table which you can keep it in your sonography room, that when gestational sac is going to appear like 4.5 to 5 weeks, yolk sac will appear 5 to 5.5 weeks. At 6 weeks, embryo will appear. Cardiac pulsation will begin with a lower limit of 100 beats per minute. Amniotic membrane appears at 6.5 to 7, and cardiac pulsation lower limit is 120 beats per minute. 7 to 8 weeks, you can see spines developing. At 8 weeks, head curvature separates from the body and 4 limb buds appear. An intrinsic motion of embryo are seen around 8 to 8.5 weeks, and between 8 to 10 weeks, rhombencephalon develops. Suppose if your patient doesn't remember her LMP and you see these features, you can go back and tell that probably your LMP is this. So this is very important to know developmental milestone. Now, can we predict miscarriage? I think with good high resolution ultrasound, and we know the features, what appears when, and what is the decidual reaction and how, I think we can predict miscarriage. And especially women who have previous miscarriages, they come with a question, doctor, can you tell, am I going to have a miscarriage in this pregnancy as well, or my pregnancy is going to be an ongoing pregnancy? So there is a good article in American Journal of Obs and Gynae, prediction of pregnancy loss by early first trimester ultrasound characteristics by Elizabeth G. Wilbis. And there are other articles also. According to this study, low fetal heart rate and small crown rump length, that is less than 122 to 123 heartbeats and 158 beats per minute, less than 6, 8.5 and 10.9 millimeter for gestational weeks 6, 7 and 8 weeks respectively. They were independent predictors of clinical pregnancy loss, with greatest risk observed for pregnancy having both characteristics, that is low fetal heart rate and a low CRL. So that is a relative risk is 2.08, 95% confidence interval, 1.24 to 2.91. So combination of low fetal heart rate and small crown rump length was linked to a 16%, that is 95% confidence interval, and 9.1 to 23% was the range. Abnormal yolk sac diameter or the presence of a subchorionic hemorrhage did not improve prediction of clinical pregnancy loss. Though we measure yolk sac diameter and say if it is more than 50, then it is going to be, it will get into miscarriage. But I think there's a more, according to the studies, low fetal heart rate and a crown rump length is more linked to the prediction of miscarriage rate. So location of gestational sac is also very important in predicting the pregnancy outcome. This is a normal location of pregnancy. And if you look here in the second picture, the location, it's a low implantation. And the second thing is decidual reaction. If the decidual reaction is thin, then it is likely that yes, the progesterone support is less and this pregnancy might end up into miscarriage. So what is decidual reaction? It is the thickening of endometrium around the gestational sac. Like this is the decidual reaction. A thin decidual reaction less than 2 millimeter is sign of suggestive of an embryonic pregnancy. So these are small subtle features which you keep in mind can really give you a prognostication of pregnancy. The yolk sac. What are the signs? By looking at yolk sac, can you say that it's an impending demise? Absence of yolk sac in presence of embryonic pole is a sign that probably this pregnancy is not going to do well. Distortion in shape and contour of yolk sac. There's opacification of yolk sac and floating central location of yolk sac within gestational sac, and significant variation in size of yolk sac above the mean, above or below the mean is also an indicator of failing pregnancy. Then another thing is tight fitting embryo. The difference between CRL and gestational sac less than 5 millimeter indicates greater risk of demise. And if the pregnancy does progress, there is a greater risk of preterm delivery and low birth weight. So it is such an important thing that if you pay attention to detail, even if there is a cardiac activity there, but you see in this picture, the gestational sac and the embryo, you see it's such a tight fitting embryo in the gestational sac. So even if the pregnancy continues, you have to put a red mark on that or put a star that yes, we have to keep a close watch on this pregnancy, and somewhere mention that there is a risk of preterm delivery or low birth weight. So likewise, patient gets monitoring more frequently and accordingly. It's very important to look at the fetal heart rate. What we find in the sonography report, invariably cardiac activity seen. It's important to put the number to cardiac activity, whether it is 98, whether it is 100, whether it is 76 or 120. So heartbeat may be below 100 beats per minute, but this will increase in between 120 to 180 beats per minute by 7 weeks. In the early scan, when you're doing 5 to 6 weeks, visualization of heartbeat is the important thing. Failure to identify fetal cardiac activity in an embryo whose overall length is greater than 4 millimeter is an ominous sign. So this is again very important to know at what size of embryo you should be seeing the cardiac activity. Now, as I already said, it's not just the presence of FHR. It is important, the rates. So this is a graph which is very important. Like if it's an embryonic heart rate is slow, Between gestational age 6 to 6.2 weeks or CRL 1 to 4 millimeter, less than 90 per minute, that is called slow. It is suspicious for impending pregnancy failure. Borderline 90 to 90 beats per minute. Gestational age 6.3 to 7 weeks. CRL 5 to 9 millimeter is slow, less than 110 beats per minute. Presence of large subchorionic hematoma. Hematoma surrounds at least 2/3 of gestational sac is also an impending pregnancy failure feature. And small gestational sac size in relation to embryo that I've already said, mean sac diameter, CRL less than 5 is an indicator of not good prognosis. There are certain other features you can predict pregnancy failure. Embryo with no cardiac activity, CRL 7 millimeter, you know it's not going to come, and you can do a counseling accordingly. Gestational sac containing no embryo. Mean sac diameter 16 to 24 millimeter. Large irregular gestational sac, you know that it is a pregnancy which is getting into the miscarriage. There are certain time-based finding. Time-based finding means no embryo with heartbeat on follow-up scan, 7 to 13 days after the initial scan. Because what happens when a patient comes to you for initial first scanning you are doing, sometimes you're not certain that you know how to label this pregnancy, whether it is a good pregnancy or it's not going to be good. You can call after 7 to 10 days and compare it. That's called interval scan. So in interval scan also, you're not seeing the heartbeat, then you know that this is not a good pregnancy. No embryo with heartbeat on a follow-up scan, 7 to 10 days after initial scan, that showed a gestational sac with a yolk sac. No embryo with heartbeat at least 6 weeks after LMP is also an ominous sign. When there is an empty amnion seen adjacent to yolk sac with no visible embryo, or if there is an expanded amnion, embryo with no cardiac activity with amnion visible around it, or enlarged yolk sac that is more than 7 millimeter is a sign of non-viable pregnancy. This is a picture of missed abortion. What you see here is a good gestational sac. There is an amnion, and look at the embryo. This is not a very turgid embryo. This looks like a very embryo which is very soft, and the CRL is only gestational age is 7 weeks 4 days, while her pregnancy was 9 weeks around, and you see that CRL is coming to 7 weeks 4 days, and there was no cardiac activity. So this is a very obvious picture which I think everyone can diagnose that this is a missed abortion. Another thing which I mentioned is irregular gestational sac. So here what you see, the empty gestational sac with there's an irregularity, that's again a sign of non-viable pregnancy. I have already mentioned about the yolk sac. Look at the yolk sac, and on the outer border of the yolk sac, the embryo appears. Here you see a floating yolk sac, which I have mentioned. That's a large and a floating yolk sac in the cavity is again an ominous sign of non-viable pregnancy. Here we see in this picture, the pregnancy is around 10 weeks, while there is a yolk sac, there is a amnion, means pregnancy gone beyond 7 weeks, and this is a CRL, which is quite small. And here again, you see there's a tight fitting gestational sac, there's an amnion, and this is a CRL, which is approximately about 7 weeks, 1 day, at 9 weeks, 4 days of pregnancy. This is a blighted ovum where the embryo never appear, irregular gestational sac, yolk sac, but there is a no fetal pole. So there is always, sometimes it happens, how many times you will frequently call the patient, you are seeing yolk sac, but you're not seeing the fetal pole. You can't keep calling the patient. There are certain limits of gestational sac diameter. At that diameter, if you don't see a fetal pole, you have to call it a day, and you have to say it is not going to go on as a healthy pregnancy, and it is a non-viable pregnancy. Again here, what we are seeing in this picture at 10 weeks of pregnancy, very tight fitting gestational sac, and the embryo, you can see a little bit of edema around the fetus as well, and there's no cardiac activity in this fetus. Then retrochorionic hemorrhage. This was a pregnancy where there is a big retrochorionic hemorrhage. There are women will come with the bleeding in pregnancy. That's the most common indication to perform sonography in early pregnancy. How do you do counseling? Depending on the size of the retrochorionic hemorrhage, whether it is, what is the probability of continuation of pregnancy can be said depending on the size of the retrochorionic hemorrhage. And so threatened miscarriage, there's a vaginal bleeding, closed internal loss, and a cardiac activity present. That is a threatened miscarriage. This was our one of the IVF twin pregnancy. There was a large retrochorionic hemorrhage. We had 2 live embryos, but with the retrochorionic hemorrhage, there was one twin with demise, and we ended up with one handing over the one baby. So this is a pregnancy where there's a dilated cervical canal, and this is kind of a inevitable miscarriage when the cervical canal is dilated. Now, this is a very important slide which helps me in counseling my patient, that living embryo and threatened abortion. How do you do a counseling? Because women will come, they will be on your head that tell me, doctor, what are my percentage of chances of losing this baby or carrying this baby? So presence of an embryonic heartbeat is highly reassuring. When you are visualizing it by low resolution abdominal ultrasonography, more than 90% of pregnancies will continue. That's a fact. Visualization by high resolution vaginal sonography is associated with a 70% continuation rate. At less than 6 weeks, if heartbeat with bleeding, and 33% of pregnancies will be lost, and 16% are lost if there's no bleeding. At 7 to 9 weeks, you have a scan, heartbeat is there is a bleeding, 10% pregnancies will be lost. 5% will be lost if there is no bleeding. So in spite of bleeding or no bleeding, some percentage of pregnancies will be lost. So you have to do counseling accordingly. And heartbeat at 9 to 11 weeks with bleeding, 4% will be lost, and 1 to 2% are lost without bleeding being present. So prognosis for the living embryo improves as gestation proceeds. So that's how your counseling should be guided by this kind of percentage. So inevitable miscarriage is when vaginal bleeding with an open cervical os, fetal cardiac activity may be present or may be absent. Here you see, though it's a second trimester picture, but in first trimester also, like I have shown the picture before, that there was a cervical canal dilatation, but here, like you can see U-shaped cervix and internal os is open and fetal limbs are visible in the cervical canal. This is a picture of incomplete miscarriage, expulsion of fetal or placental material, but some remnants are there in the cavity. Patient keeps continuing bleeding. You may do the medical method, or depending on the symptoms you can use. Now, I think I'm done with my time, but just a couple of slides about safety of Dopplers in early pregnancy. According to the World Federation of Ultrasonography, recommends that ultrasound causing a temperature rise of no more than 1.5 degrees centigrade may be used without reservation on thermal grounds. Follow ALARA principle. Thermal exposure can be teratogenic. A rise of even 2.5 degree has been found significant in guinea pigs. A diagnostic exposure that elevates embryonic and fetal in situ temperature to 4 degrees centigrade for 5 minutes or more should be considered potentially hazardous. So this is ICOG statement of safe use of Doppler in 11 to 13 plus 6 weeks fetal ultrasound examination. So what I'm trying to tell, when you are doing an early pregnancy scan, say less than 10, 11 weeks, do not put your power Dopplers, just aim mode, you see the heartbeats. And if you are taking if you are a teacher or if you are taking the students, when we should not be, demonstrating with the Dopplers for a longer period of time because it raises the temperature. So practice points, pulse Doppler should not be used routinely. I already mentioned pulse Doppler may be used for clinical indication such as to refine risk for trisomies. And when performing Doppler ultrasound, the displayed thermal index and exposure time should be kept as short as possible and should not exceed 60 minutes. And when using Doppler ultrasound for research, teaching, and training purpose, the displayed thermal index should be less than 1 And in educational setting, discussion of first trimester pulse or color Doppler should be accompanied by information on safety and bioeffect. And when scanning maternal uterine arteries in first trimester, there are unlikely to be any fetal safety implication as long as embryo or fetus lies outside the Doppler ultrasound image. So take-home message from this is improvements in ultrasound technology over past 3 decades, especially the introduction and dissemination of transvaginal ultrasound, have made ultrasound an increasingly valuable tool. It is available. It is not that expensive. And it can be learned. Early pregnancy scan can be learned, like in today, like by the ICOG. FOGSI also runs courses and several workshops. You can learn to do at least ultrasound of post trimester, and it is our responsibility to use this tool carefully and judiciously and know the red flags in ultrasound. And these are the references from where I have taken few figures and percentage. So thank you so much for patience listening. And if there are any questions, I'm happy to answer.
Yeah, Archana, he will have to answer in the chat box.
Okay.
Yeah. So please.
Yeah, I think that was a wonderful presentation and absolutely crystal clear. So we can move on to the next one now.
Yes.
Thank you.
Yeah, thank you, Dr. Archana. It was very nice to talk. And so now we go on to another topic. And now I invite Dr. Pooja Lodha. She will be speaking on prenatal screening in first and second trimester. And Dr. Pooja, she is the director at, are you showing the CV? Okay, Dr. Pooja, she is very active member of Pune Obs and Gynae Society, and she is the director at Kangaroo Cradle Fetal Care Clinic, State-of-Art Fetal Medicine Center at Pune. So we welcome you, Dr. Pooja, and we are waiting to hear from you.
Thank you so much for the kind introduction. At the outset, I'd like to thank FOGSI and ICOG, especially Dr. Rishikesh Pai sir and Lakshmi Shrikande ma'am, for this prestigious opportunity. I hope I do justice. It's a 20 minutes, 2 trimesters and a lot of markers. So it's going to be a marathon, and I will try to focus on the most important points. So prenatal screening in the first and second trimester is the talk. And today we will go through screening versus diagnostic testing. It may appear to be very basic, but that's what is the base that we need to have really strong before we know what the markers are and what tests to be performed in whom. We look at the first trimester aneuploidy markers and the second trimester soft markers. Once seen, what do we do next? The references for today's talk are from ICOG guidelines, International Society of Obstetrics and Gynaecology, the Fetal Medicine Foundation, and yes, the patients are the best patients who teach us all the patients that we need to look at all these markers. So what is screening? Screening is something that we apply to everybody, and that means the low risk population. Now, once we screen the population, we find that there are some women who are high risk and some who are low risk. So that a group of women is low risk, which then would be subjected to the routine surveillance. And there is a group of women, a smaller group of women, which would be high risk, to whom we do special tests. Now, these group of high risk women are subjected to what is known as a diagnostic test to decide whether these high risk women actually are carrying a normal fetus or they really are carrying affected fetuses. So the diagnostic test is the final test applied to a group of high risk women, which we find on screening the whole population. So as pertaining to Down syndrome screening, now why all this fuss about Down syndrome and no other syndrome? Because Down syndrome is the commonest chromosomal abnormality found in a mentally not normal life child. So which is why we concentrate on Down syndrome. And why is it more tricky as compared to Edward, Patau and other syndromes? Because Down syndrome may show us really subtle hints on scan, unlike trisomy 13, 18, 16, which will show us either abortions or gross defects, which are very difficult to miss. Whereas Down syndrome babies, there is a lot of overlap with normal features on ultrasound, and therefore a lot of this prenatal diagnosis and screening is pertinent to Down syndrome. Now, we have already spoken, there are 2 kinds of tests, screening and diagnostic. What are the screening tests? It can either be done through the mother's blood, which is a double marker, or we can do it through ultrasound, which is the first trimester and the second trimester. We'll go through them. What are the diagnostic tests? There are 2 diagnostic tests that can be performed on the fetus, in fact, in pregnancy. One is between 11 to 13 weeks, which is the chorionic villus sampling, and another is between 16 to 20 weeks, in fact, 16 weeks onwards, which is the amniocentesis. Okay, so what has happened over the last decade is a complete inversion of the pyramid of antenatal care. And that 90% of chromosomal abnormalities are being diagnosed as early as 12 weeks. So instead of late booking, first scan at 16 weeks, looking at soft markers, hypoplastic nasal bone and nuchal edema in the 19-week scan, we have now moved to more specific markers at the 12 weeks, and we can detect over 90% of chromosomal abnormalities with only a good first trimester ultrasound. And let's see how to do that. Now, it's not just the chromosomal abnormalities why 12-week scan is important. If you just look at an NICU admission status, you see that there are very few deletions, duplications, downs, and trisomy 18s in the NICU, but there are way more number of neonates with low birth weight, preterm births. So these are the problems that we are facing. And over the 3 days, you would hear the advantages of 11 to 13 week scan is not just limited to the Down syndrome, but also to structural defect diagnosis, to preterm birth prediction, to diagnosis of high uterine artery PI, which is a very good predictor for preeclampsia. And all of this can be done at 12 weeks. And therefore, this is a very important window for us to prognosticate the mother as well as the fetus. So what does this 12-week window of opportunity help us do? It helps us screen for chromosomal abnormalities, for diagnosis of fetus structural defects and abnormalities, screening for small for gestational age fetuses, screening for preeclampsia through uterine artery and PAPE. We'll come to that. Screening for preterm delivery, and yes, complications in twins, because 12 weeks is kind of the last check where you can find out the chorionicity very nicely, and chorionicity is what determines all the complications in twins. So this is why the 12 weeks is known as the OSCAR. It is a one-stop assessment of risk for the fetus, risk for the mother. Now, today, the scope of the talk is going to concentrate on aneuploidies. Now, aneuploidies means wrong number of chromosomes. It could be more chromosomes, it could be less chromosomes, it could be chromosome number 21, 16, 18. This is what aneuploidy means, okay? Now, 11 to 14 week scan is the best time to screen for aneuploidies on ultrasound and combine it with a blood test. Now, do we do a good NT scan for everyone, or do we only do it for the elderly? We do it for everyone because age is not a good screening test alone. So initially, we used to, around a decade back, these tests were all reserved for elderly women. But over the period of time, we have now realized the importance of doing it for everybody, because although the risk of Down syndrome is more for women over 35 years of age, but if we look at the total number of women who are born, the numbers, the absolute numbers are way more in the age group of 18 to 35 as compared to those above 35. So in short, there are more number of Down syndrome babies being born to women between 18 to 35 years of age as compared to elderly. So if we screen only the elderly, we are going to miss out on all these young women who are giving birth to Down syndrome babies. And therefore, do not say that she's just 20, no NT scan, no double marker. She's 40, let's do a double marker. No, it's for everyone. It's a universal screening. Now, what's the best time to screen? The best time to do a first trimester aneuploidy scan is between 11 and 13 weeks, 6 days, which corresponds to 45 to 84 millimeters. So if there is a delayed or early conception, make sure you don't look at the weeks, but at the CRL. So the CRL has to be between 45 and 84 millimeters for you to do an aneuploidy screening in the first trimester. What are the 2 modes of screening at first trimester? You do a double marker in the mother, and you combine it with the aneuploidy scan features. What are these aneuploidy scan features? The first and foremost, the most important is the nuchal translucency. How many ever new markers come up on ultrasound at any gestational age? Nuchal translucency continues to be the boss of aneuploidy screening on ultrasound. Okay, I'm talking about ultrasound markers. So what are the ultrasound markers you look at 11 to 13 plus 6 weeks to give a risk for Down syndrome or aneuploidy? Nuchal translucency, nasal bone, ductus venosus, and tricuspid regurgitation. Now, the first two are the most important ones, but the next two are optional ones. So if you are starting to do your 13 NT scans, make sure you master your NT very well rather than trying to go and learn how to do a TR and DV. Okay, so it's much more important that you do a very proper nuchal translucency and look at the nasal bone rather than trying to rush in for these new and minor markers, which are the ductus venosus and tricuspid regurgitation. And why do I say so? Hardly ever or usually never will you find a fetus who's got a very normal NT, a good nasal bone, an abnormal ductus, and turns out to be Downs. Okay, so these are minor markers. You don't take decision based on basis of them, and therefore please master your NT very well before you start doing other markers. This is how your first trimester scan report looks like. What all are you supposed to see? First and foremost is you look at the heart rate, you document number, like ma'am just said, don't say fetal cardiac activity present. You have to mention the number, because bradycardia, tachycardia, how much is the heart rate decides a lot. It's in fact even a part of the aneuploidy screening. Then you look at the crown rump length. If there is a difference of more than 1 week between the gestational age on ultrasound versus the gestational age by LMP, you redate the pregnancy depending upon the CRL on scan today. So what is the best time to date the pregnancy is now. It's not at 6 weeks, because at 6 weeks you can hardly see the crown and rump properly. I may say that the 6 week embryo is 8 millimeter, you may say it's 6 millimeter, and that's going to be a huge difference in weeks. Therefore, we all agree that 10 to 14 weeks, in accordance to even ISWA guidelines, is the best time to measure a proper crown lump length optimally and redate the pregnancy if there is a difference of more than 1 week. You don't go and date every pregnancy, okay? You date it only if there is a gap of more than 1 week. Another situation you don't date a pregnancy despite a discrepancy is an IVF conception, because in IVF conception, you have already dated the pregnancy according to the embryo transfer. Now coming next, you need to document a nuchal translucency, mention if the nasal bone is present or not, a ductus, a tricuspid. You write the uterine artery PI left and right, and it gives you the mean. You find out the cervical length, and you mention the placenta. So this is what a first trimester report should look like, and not just NT is so-and-so, CRL is so-and-so, okay? Now, another aspect of first trimester aneuploidy screening is a double marker. This is the blood test to be done in the mother. It tests for trisomy 13, 18, and 21. When is it to be done? It can be done between 10 weeks to 13 weeks and 6 days. But for convenience, most of us do it immediately after the NT scan. Can you do it the next day after NT scan? Yes, you can. Can you do it 3 days later? Yes, you can. As long as the pregnancy gestational age is less than 13 weeks, 6 days, you can go ahead and do a double marker from a good accredited genetic lab, who will then combine the double marker along with the maternal age and the ultrasound markers to give you a final risk. Now, what is this final risk? We'll just come to that. Components of double marker, like the word says double, it's free beta HCG and PAPE. Normally, it's supposed to be 1 and 1. If the HCG is high and the PAPE is low, this is a trend towards Down syndrome, okay? But this is a trend towards trisomy 13 and 18. You don't need to put your brain into this, because the lab is going to give you these risks, but it's just if you try to read these markers, you will find out this is the trend you find. Now, coming to reading of the report, how does it look like? A lot of times we face this problem, how to interpret this. If you just see The age risk is 1 in 603. Age risk is the risk that the mother got pregnant with. It cannot be high or low. If this is a 28-year-old mother who got pregnant at the age of 28, her risk for having a baby with Down syndrome is 1 in 603. Once you are doing a double marker, doing an NT scan, combining all of this, since everything is normal, you have now put her into a risk of 1 in 6,358. So while you talk to the couple, you can tell them, when you started off the pregnancy and had not done any test, imagine yourself in a room of 600 people. You could be one of them with a baby with Down syndrome. But now that you've done these wonderful tests like double marker and an NT scan, we've been able to shift you to a bigger ground with 6,000 people. And now you are one amongst them. So probability has gone down manyfold and you are now very low risk. This is how you can counsel a lady once you've got the double marker report. Now coming to the soft markers, which is the second part of the scan, of the talk. Now, a lot of times we miss a first trimester scan. Our women don't turn up. They go to their villages. They don't understand the importance of an NT scan. Some of them are late bookers at 16 weeks. So what do we do next? Now, this is a genetic sonogram. And yes, these words scare us. I've tried to simplify it. 19 weeks is genetic sonogram. And we, of course, do it with the anomaly scan along with all that is mentioned on the slide. But let's concentrate on the genetic sonogram or the markers for aneuploidy in the second trimester. Whom to offer? Everybody. Okay. Like we said, age is not a good screening test. You have to do a good scan and a good either a double marker, or if she misses a double, you can do a quadruple marker. Mind well, please note triple marker is obsolete. Just for another 100 extra rupees, if you're getting a better test, which is a quadruple marker, which has got a much better detection rate, please go in for a quadruple marker if she's missed a double marker. Having said that, double marker and a 12-week scan continues to be the best mode of universal screening in a country like India. And there I'm not touching on NIPT to confuse the situation. Something that can be applied to everybody, NT scan, double marker. You do this properly and you're picking up 95% of your Down syndromes, which is actually a very good screening test. What are soft markers? You find them at 18 to 23 weeks. They can be seen in normal fetuses, but they are seen with a higher frequency in babies who have aneuploidies. Now, if you find a soft marker on scan, it could be either of these, and that's what confuses the situation. It could be a normal variant, it could be a chromosomal abnormality or a non-chromosomal abnormality turning into a structural defect. Let's take an example. Now, there is a mild ventriculomegaly at 19 weeks. This could be seen in a normal baby. This could be seen in a Down syndrome baby as well. And this could be seen in a fetus who has a genesis of corpus callosum, and hence the baby is showing a ventriculomegaly. Okay, so the whole importance lies, once you see a soft marker on scan, you got to look harder and search for more. Because only if the rest of the baby is normal, you can call this soft marker as isolated and then be more reassured with the help of more tests. Now, this is the list of common soft markers that we get reported from the radiologist or your fetal medicine specialist. And I will run through them very quickly. If you see them, what do you do next? Okay. So on the right side, you'll find some numbers here. I won't confuse you with PSM, but pooled likelihood ratio simply means, for example, if you see a hypoplastic nasal bone, this baby is 6.5 times more likely to have Down syndrome as compared to a baby who has a normal nose. Okay, that's what a pooled likelihood ratio means. And these charts are freely available online. If all those who are interested, I can post the link where you find these charts free of cost. You take an Excel, you put it on your desktop. As soon as you get an anomaly scan report, you see, okay, what is the pool likelihood ratio? This will help you answer the chat box data. Now, coming to case scenarios here, 31-year-old come for an anomaly scan. There is an unexpected echogenic focus. Now, reporting intracardiac
Pooja, your voice is
has
cracking.
intracardiac echogenic focus. This baby is only 0.9.
Pooja, your voice is cracking in between.
Okay.
Yeah, please go ahead, Pooja. Hello. We have lost her.
I think she has lost the connectivity.
Her voice was cracking in between. Pooja? Then Richa, I think you can introduce the next speaker.
Yeah, I
And
think so.
she can answer all the queries in the chat box once Pooja logs in.
We'll call her up to answer the queries. And then now we move on to the next topic. That is tubal ectopic medical and surgical management video presentation by Dr. Kiran Pandey. So can I request Dr. Aarti to introduce Dr. Kiran?
Yes, can I have ma'am's CV slide, please?
You can introduce
Just,
without
yeah, I will
slides
just
also in short. Yeah.
Should I introduce?
Yeah, please, anyone.
Yeah, Kiran Pandey ma'am. She is the chairperson of Medical and Educational Committee, FOGSI. She is the professor and ex-HOD in the OBGY department in GSVM Medical College, Kanpur. She is the chairperson of the IMA WDW, and she is having the teaching experience of more than 36 years. We welcome you, ma'am. Please start the screen sharing.
Okay, thank you. But there's a lot of instability into the. Am I clear? Audible?
Yeah.
Yeah,
You are
you
audible.
are.
You are audible.
But
Yes.
somehow it is. Let me share with the. Sorry. Are you able to see my?
Yeah.
It is visible.
But just a minute. I think I'll have to start from the beginning. I have somehow on the fag end. Right. So at the outset, I'm very thankful to Dr. Lakshmi Shikande, Dr. Richa Sharma, and the FOGSI team, FOGSI president, for giving me this opportunity. My topic is quite simple. Tubal ectopic pregnancy, medical and surgical management. And basically, as all of you know, everybody knows that just to give an idea that ectopic pregnancy is an implantation outside the endometrial cavity. And in India, the incidence is almost 0.91%. And the case fatality ratio has decreased over the recent years. Of course, the credit goes to early diagnosis and its treatment, and that is what we have to focus on. Well, almost 90% are in fallopian tube ectopic pregnancies, and out of those 90 to 95%, we know that it can be in different parts, interstitial 2 to 3%, ischemic 12%, maximum is in ampullary, that is 70%, and femoral 11%. And besides, there are other ectopics also, which will be discussed by the other speakers like cervical, cesarean, scar, etc. Basically, these patient presents as a pelvic pain, and although sometimes intermittent spotting, they might not even give the history of any overdue or loss of menses. And it's more of a discomfort. Pain can also be in the form of discomfort, nausea, vomiting. Syncope is also very time. Sometimes no other premonitory complaint is there. Patient first time presents as a syncope, lightheadedness. Then when you ask the history later on, then you come across that she had a scanty periods and there was some intermittent bleeding also. Always consider in a young age, childbearing age, that the possibility of ectopic pregnancy has to be. My teacher used to tell us that even if she is not pregnant but presenting with these symptoms, keep it in mind always the ectopic. So that is what is the basic thing. Now, Basically, how the most important tool for diagnosis, as we all know, so much is being discussed, high-fi, but here the only important thing is transvaginal ultrasound is important diagnostic tool, and it is very important to identify it positively, and which can be done by visualizing the adnexal mass, which is separate from the ovary, possibly unless and until it is a chronic ectopic where it becomes a mixed up mass and complicated mass. Otherwise, usually initially, if it is diagnosed, it is seen clear, comparatively separate than the ovary. Now, in biochemicals, basically serum beta, I'm just giving a little bit of idea before I reach to the video presentation very soon. So the serum beta SCG is the most useful in the management of ultrasound. Others are not, like progesterone, etc. we don't do. In the treatment options, there are three options. It can be an expectant, it can be a pharmacological or medical, or it can be a surgical. Now, who are the patients who can be given expected management? Before we actually reach to the surgical, I would like to discuss a little bit about these two things. Now, if the first thing is, of course, diagnosis of ectopic by transvaginal ultrasound, patient has to be stable, willing for doing expectant management, and the most important thing, she can come for follow-up. If she's going far away, she can't come. No question of doing expectant management. Pain is not very severe. The HCG, beta HCG levels are either low, which should be less than 1500 international unit per ml, or they are in a declining phase. If these are the features, then of course we can go ahead. Reported success rates are 57 to 100%. Depends, of course, how religiously you select the case. Now, in medical management, of course, the drug we all know, systemic methotrexate, which is the most common drug. And various RCTs have compared it to laparoscopic surgery in selected cases, and they have found that it is equally successful, provided the criteria have been considered properly and not variations. It should never be given at the first visit unless we are very sure that this is a case of ectopic, and it is clear that this is not a viable intrauterine pregnancy. This has been excluded. So normally it can be given in a single dose or multiple dose. You must have all gone through this, but the most important is the single dose is the most commonly used, and that is given as an intramuscular dose, 50 milligram per square meter. And serum beta HCG levels are measured on day 4 and 7 post methotrexate. If they are decreasing by 15% or more than that on day 4 and 7, meaning by we are in the right direction, and we can continue with the treatment, and the weekly measurement of beta HCG can be done. But if the level does not decrease by 15% or it is lesser, then we have to repeat the transvaginal ultrasound. See, supposing the significant hemoperitoneum means the ectopic is ruptured or the cardiac activity has come. If such has become, what can we do? One option is, of course, surgical shift to, or we can even give a second dose of the methotrexate. And it has been seen that overall success rate of single dose is quite good enough, 65 to 95%. Only in 3 to 27% of women, second dose of methotrexate is required. Now, multiple dose, this also, when we were doing in the initial stages methotrexate, right? Then we used to give 1, 3, 5, 7. Methotrexate is given in the dose of 1 milligram per kilogram intramuscularly on day 1, day 3, day 5, day 7, alternately leucovorin 0.1 milligram per kilogram per intramuscularly, day 2, 4, and 6. The important thing is every time on 3rd day, 5th day, and 7th day, the serum beta HCG level have to be done, and the decline has to be more than 15%. If it is less, we have to stop the treatment and start the surveillance and reassess the treatment which we are giving. So that is the basic principle of it is. Now, additional efficacy of multi-dose outweighs, of course, the percentage-wise, but the convenience and the lower rate of side effect does favor the single dose. The one study which I'm putting here is presented by American Family of Physicians, AAFB Journal, and they concluded that although the multi-dose regime of methotrexate is associated with significantly more side effects, but and is more complicated to administer, it is more effective, definitely. But we have to outweigh the things, how we have to do. Predictors of success is NICE recommends methotrexate should be the first line treatment for women who are able to return for follow-up, means this who are following your advice and the proper protocol. If they are not significant, no significant pain, if the ectopic is unruptured, if the beta HCG level is between 1500 to 5000 international unit, and no intrauterine pregnancy is there. Whereas contraindications are those if the patient is hemodynamically unstable, if there is a intrauterine pregnancy, patient is breastfeeding, unable to comply to the follow-up, known sensitivity, chronic liver disease, pre-existing blood dysplasias, active pulmonary disease, immunodeficiencies, peptic ulcer disease. These are the cases where we do not have to think of the methotrexate. So with this all basic approach, because I find methotrexate is a quite good effective treatment, I took it before the surgical management. Now, surgically, of course, we have both the options. Laparoscopic surgical approach is the preferred one these days, if the all the availability is there. But supposing the facility is not there, resources are limited, expertise is not there, no problem in going ahead with the open approach also. But basic thing is patient has to be safe. And this is a very rewarding surgeries. Now, the basic thing is, if there are two, usually it's not a very complicated surgery. You will just now see. The most important three has to be that the other tube, control tube, is healthy or not. If it is healthy, self-injectomy can be performed in preference to self-ingotomy. So here you can see this is a lady who is presented to the outdoor with a pain in abdomen, and she is with the fresh blood is seen here. So you can understand it is a freshly ruptured ectopic pregnancy. Few blood clots are also there, and this is being cleaned with the suction cannula, and all the clots are being removed. And you can see on the left side, the tube is clearly seen to be dilated. And with the help of a traumatic grasper, we are pushing the tube up, and all the clots are being removed properly. And because only then one can see it clearly. So it is seen that the tube is clearly distended, and it is in fact actually tubal abortion is happening here. Now, the tube is held, and you can see the cell with the help of energy for tissues, the tube is removed. The most important thing, if you can see here clearly, that it is the tube has to be like cauterized and cut at the tubal border, at the close to the, as close as possible to the tube. Otherwise, we all know there are lots of vasculature, even anastomosis into the tube, and which will be affected. Hematoma will form. Another important thing is this has to be done up to the cornual end. Otherwise, in the residual, if a stump is left, this will be another chance for another ectopic. The tissue sample is being kept into the bag, and this is being removed from the left iliac side porta. The other tube is being seen. It was actually earlier also checked that it was normal. Again, it is checked. The normal saline has been put so that all the blood clots and everything is being removed. And this is clear. Now, in those cases where the fertility reducing factors are already there, we cannot do the self-injectomy. Patient has, supposing, had a previous ectopic pregnancy, or the contralateral tube is already damaged, or the abdominal surgeries have been done previously. History of pelvic inflammatory disease, where there are chances that the other tube is also damaged. In those cases, salpingotomy should be considered because we have to save the the fertility of the patient. So here is a case of 28-year-old lady. She's gravida 1 with left pelvic pain, and on ultrasound, you can see the uterus is empty, endometrium is seen, and the adnexa, clearly there is a mass, adnexal mass is seen, which is vascular. On opening, there's a abdominal cavity is full of clots, and compared to the previous case, it is little ruptured earlier. So blood clots have been formed. They all have to be removed so that the clear visibility is there. And one can see again, it is the left tube, which is showing itself dilated. And here, this is the most prominent part of the tube, and which has to be inside. But before that, you'll see in a minute, second, that this other tube, here is a very interesting finding was there. This part of the tube, you see clearly, is a thin bend, and there is you can see it is congenitally obstructed. There is no connection from the distal part of the tube to the proximal part. So this tube is useless for the fertility point of view. And therefore, there's no possibility that salpingectomy should be thought of. And so the decision for salpingotomy has been taken. And this, with the energy-based device, the incision, now it is given on the anti-mesenteric border. So incision has been given, and you can see the ectopic, the gestational sac is bulging with gently with the probe itself. It is being separated from the sac is being separated from the wall, and it is held by the atraumatic tubal, the atraumatic forceps. And very gently it is being pulled out, so that possibility of the whole tissue is coming out. This you can see clearly the tube here, and we should try that no chorionic tissue should be left inside as much, because otherwise it will be left, then there will be bleeding and there will be other problems, and it might grow. So one should try as much as possible to take out all the chorionic tissue, and then that is what is the thing. So it is removed. Now, still, once you perform the salpingotomy, the chances of some persistent trophoblast remains. And so here beta SCG has to be done for follow-up. And if the patient is an Rh negative, then NTD prophylaxis as per national protocol has to be given. Where the bleeding is, if the bleeding is repeatedly occurring, heavy associated, so depending on that, according to the protocol, it has to be given. Now, this is what basically the surgical, it's not actually for a surgical, but I found when I was finishing the presentation, I found one study which was showing this was done to evaluate a decreasing HCG between day 1 and day 7. Should we do a day 4 analysis also? So I thought I'll just include it into. It is a better predictor for tubal ectopic, and in this study, out of 7,350, 301 women, 4.1%, were diagnosed to have tubal ectopic, and they were managed expectantly, methotrexate, and surgically. So this study was showing all comparatives. So I thought, let's understand it. Expected management, quite a significant 27.9% responded, with methotrexate 21.6%, and surgically 50.5%. Basically, the predictor was between day 2 to day 7. HCG ratio was seen, and the positive predictive value was 0.84, and negative was also 0.84.
Dr. Kiran, if you could please wind up, because you've already
This is the last
overshot.
slide. Aranjana, this is the last slide. Thank you very much. So just to conclude that tubal ectopic can be managed both by methotrexate and by the ectopic. Thank you very much. Oh, I'm sorry. This is the last slide. Thank you very much, Ranjana. Sorry if I second few seconds more. So once again, thankful to Dr. Lakshmi, Dr. Richa, Dr. Ranjana for giving me this opportunity.
Thank you, Kiran. Thank you so much. And you can answer queries related to your
Yeah.
topic in the chat box. Pooja,
Right.
if you are here, please resume your talk.
And it was a wonderful talk and a wonderful
Yes.
video at that, Kiran.
Thank you so much, Dr. Rana.
Thank you,
so
Dr.
much.
Kiran. It was nice
Yeah,
presentation.
you will
Yeah.
stop your screen sharing, Dr. Kiran.
Yes,
I can share.
I'll stop. I'll stop.
Yeah, yeah.
Right.
Pooja,
Thank you so much.
start. You can unmute yourself. Yeah, Pooja.
Can you hear me now?
Mitali.
Yeah, we can.
करो Dr. Pooja को.
I am unable to share the screen. Host, can you please enable?
You can co-host Mitali, Jignesh. Yeah. Now you are Pooja.
Okay, yes, ma'am. I'm very sorry for the hit. I hope I can now be seen. Okay, so we were on the second trimesters and we were talking about the echogenic focus. So once you see an intracardiac echogenic focus and everything else
Can't
is
see your
fine.
slides. Pooja, have you shared?
We can't see your slides.
Pooja, have you shared screen? We can't see.
Yes, ma'am. I'll reshare the screen.
Please, there is some issue.
Now can you see it, ma'am?
No, no. Pooja.
No.
Not seen?
No, no. I think there is some net issue.
Okay.
I think we have to make her the co-host. Yeah, now we are visible.
Yeah, they made me the co-host.
But your
Yeah.
your screen, yeah,
Now
now.
it is coming.
Now it's coming.
Okay, now yeah, just 1 minute. I'll share it.
Yeah. Take your time.
Okay, please let me know if you can now see my screen.
Yeah, it is coming.
Yeah.
Okay.
Yes,
We
yes.
were talking about echogenic focus. If everything else is fine on scan, she's a young lady, low risk first trimester screen, we need to forget about that intracardiac echogenic focus. Okay, reassure the couple and move ahead. Make sure this rest of the list is normal in the baby. Okay, this was the Excel I was talking about. If any of you are interested, I post a free link to this live Excel. You just keep clicking present, absent, and the end number that you get is how you counsel the couple. So how do you counsel her? If 0.95 is what you get below, then you say that your baby is another baby with all these markers. So that's what the likelihood ratio means. So intracardiac echogenic focus is very common in Asian mothers, seen in as high as 3 out of 10 normal babies. It's that common. Okay, so its importance in aneuploid babies is reducing unless you see something with an ICF. Okay, these are the questions that the couple will have at us. Will it go away before delivery? May or may not. Do not worry. Do not re-scan to see if it is gone. Does it increase your risk of chromosome?
Net is again gone. She has a lot of network issues.
Yeah, she has gone. So I think Richa.
So we'll move on to the next topic, I think.
Yeah, Dr. Aruna Suman's talk.
Yeah. Okay, so our next topic is cervical pregnancy diagnosis and management by Dr. Aruna Suman. So now can I request the chairpersons to introduce Dr.
Pooja is here. Pooja, can you complete your talk and you can summarize the take-home messages to the audience without
without sharing the screen?
Yeah.
Yeah, I'll answer the questions in the chat box.
Yeah.
Sorry for this hit. I'll just tell the take-home messages.
No problem. You can just give them take-home messages.
So genetic sonogram in first and second trimester is extremely important. The presence or absence of a marker does not decide if the baby is normal or abnormal. You have to confirm it with diagnostic testing. Only then can you take a decision of whether this baby is affected or not. Ventriculomegaly increased nucleus and hypoplastic nasal bone. Be very aware of these markers. They are not soft, they are very hard markers. You have to investigate further, do an invasive testing and look for more problems. Never terminate a pregnancy without the pregnancy and make a diagnosis for the present one. Remember, NT is the boss. How much ever you do, nuclear translucence continues to be the most important. Thank you so much. Sorry for the technical.
No issues. Pooja, please share the link which you promised and answer the remaining queries before you leave. Yeah, Richa, please invite.
Okay, now can I request the chairpersons to introduce Dr. Aruna?
Yes, may we have the pleasure of inviting Dr. Aruna Suman ma'am. She is the professor and HOD of Government Medical College, Telangana, and has been the South Zonal Coordinator for FOGSI for the year 2022 and 23, and is also the Vice President of multiple FOGSI associated Obs and Gynae societies. She's also known as one of the trainers of the trainees because she's participated with multiple health programs with National Health Mission. May I now invite ma'am to give a talk on cervical pregnancy diagnosis and management, please.
Thank you, Dr. Aarti. I thank Dr. Lakshmi Srikande ma'am for this opportunity. And I also thank, can I share my screen?
Yeah, please.
Dr. Ranjana Khanna madam, Dr. Richa Sharma, and Dr. Krutika. Thank you so much for this opportunity. No, I'm not able to share my screen.
Aruna Suman को co-host बनाओ, मिताली सारे speakers को co-host बनाओ.
मैम बनाया है अरुणा मैम को.
अच्छा.
अभी बनाए हैं? Let me see.
Yeah.
Yes. Yes. Thank you so much, ma'am. Lakshmi ma'am, Ranjana Khanna madam, and Richa Sharma. Thank you so much. My topic is cervical pregnancy, diagnosis and management. Yes. What is cervical pregnancy? Pregnancy implants in the lining of the endocervical canal below the level of the internal os. There was a criteria, a histopathological criteria by Rubin in 1911. The cervical glands must be present opposite the placental attachment. Attachment of the placenta to the cervix must be intimate. The whole or a portion of the placenta must be situated below the entrance of the uterine vessels or below the peritoneal reflection of the anterior and posterior surface of the uterus, and no fetal elements must be present in the corpus uteri. So it is a histopathological examination, and this can be confirmed only after hysterectomy. So actually the incidence is very, very less than 1%. Even though incidence is very less, we have to have the good knowledge of this for the early diagnosis and management. So 1% of ectopic pregnancy, 1 in 9,000 deliveries. We see the incidence. Why does it occur? And this can occur because of rapid transport of fertilized ovum into the endocervical canal before it is capable of nidation, or because of an unreceptive endometrium. Damage to the cervix and endometrial lining during operative and uterine procedures. The more cephalate that the trophoblast is implanted along the cervical canal, the greater is the capacity to grow, and there is more chance of hemorrhage. What are the risk factors? So the risk factors are ART, the previous dilatation and curettage, previous cesarean section, Asherman syndrome, endometritis, uterine fibroids, IUCD, age below 35 and 40 years, age between 35 and 40 years, structural anomalies of the cervix or body of the uterus, and grand multipara. Although the non-tubal ectopic pregnancies account for only 5% of ectopic pregnancies, they are responsible for significant morbidity and they are life-threatening. So early diagnosis, correct diagnosis is important to save lives. How does it present? It can have painless vaginal bleeding in 90% of the women. So we have to succeed with the diagnosis, and massive hemorrhage is seen in 30%, lower abdominal pain or cramps in 30%, and few women can have pain without bleeding, and it is very rare. clinical examination. Coming to the speculum examination, this is very, very important step. Distended thin walled cervix is seen. Partially dilated external os revealing fetal membranes or pregnancy tissue which appears blue or purple. Infrequently, a cystic lesion on the cervical lip is observed and represents trophoblastic invasion into the cervical stroma. So the speculum examination, definitely we can suspect the cervical pregnancy. Bimanual examination. If at all there is a suspicion in the cervical speculum examination, we should not manipulate our finger into the cervix. This can cause torrential bleeding and it will be very difficult. If there is a soft tissue that is disproportionately enlarged compared to the uterus and hourglass-shaped uterus is seen in a bimanual examination, we have to suspect the cervical pregnancy. What are the investigations? Pregnancy test will be positive. The sonographic criteria, 87.5% accuracy will be there under ultrasound. If we do an embryo or fetus in the intracervical area is seen, gestational sac is below the level of the internal cervical os or uterine arteries. Gestational sac or placenta within the cervix is seen. Normal endometrial stripe is visible and hourglass appearance of the uterus is seen. The radiological criteria, after the Rubin's criteria, a few criteria were developed for diagnosis under ultrasound. So Raskin has developed in 1978 and Tima and Trish has developed in 1994. There's an important sonographic criteria developed by Ushkov in 1996. What does the criteria say? Gestational sac in the endocervical canal. 2, presence of some intact cervical tissue between the gestational sac and the internal os. Trophoblastic invasion of the endocervical tissue. Embryonal or fetal structure, in particular pulsating heart in the ectopic gestation. Empty uterine cavity. Endometrial decidualization is seen and sand glass appearance of the uterus and Doppler detection of peritrophoblastic arterial flow. This confirms the diagnosis. These are the few pictures that is showing the confirmation of the cervical pregnancy. If at all it is doubtful, we are not able to diagnose by ultrasound or Doppler, MRI can be done, and this gives a clear picture of the cervical pregnancy. What are the differential diagnoses and how do we confirm the diagnosis of cervical pregnancy? So incomplete abortion that is proximal to the cervix. Cardiac activity is seen in cervical pregnancy, but it is not seen in incomplete abortion. Gestational sac has a regular contour in cervical pregnancy, whereas incomplete and irregular in incomplete abortion. And cervical os is closed in cervical pregnancy, open in incomplete abortion. Incomplete abortion, aborting intrauterine pregnancy that is trapped in the endocervical canal. Resistance from the external cervical os will be there, and some products of conception blood clots are seen in the uterine cavity. The uterine cavity is enlarged compared to the cervix. The internal cervical os is open and the gestational sac is flattened, has no or minimal echogenic rim and contains no dead embryo, or sometimes it can have a live embryo also. So the best way to distinguish the situation, both the situations, is the sliding sign. What is sliding sign? Which means that when gentle pressure is applied on the cervix with the probe, when we are doing the transvaginal scan, the implanted cervical pregnancy does not slide, unlike the gestational sac of the abortion. Coming to the cesarean section, cesarean or scar pregnancy, gestational sac is in the anterior lower uterine segment. Uterine cavity and endocervical canal is empty. Cervical polyp is seen, and this is how the picture looks, and we can definitely diagnose it with the scan. So this is the cesarean scar pregnancy. The gestation sac is in the anterior lower uterine segment at the presumed site of the uterine scar. Here, the picture shows definitely there's an empty endometrial, thin arrows are showing the empty endometrium, and the cervical long arrows in the canal. Thinning of the myometrium between the gestational sac and the bladder, here it is seen. So here we can conclude the diagnosis by if that it is cervical pregnancy, an hourglass uterine shape, balloon cervical canal, gestational tissue at the level of the cervix, absent intrauterine gestational tissue, portion of the endocervical canal is seen interposed between the gestation and the endometrial canal. How do we manage this case? Suppose we have diagnosed it, and the management depends on gestational age, stability of the patient, future fertility, expertise for treating the patient. So there should be an experience, or a senior surgeon or a senior gynecologist should be there. What does the evidence say? What is the ideal management? There is no ideal management given in the literature. Each case should be individualized. I have seen 4 cases when I worked at Usmania Medical College. In 2 cases, we have done hysterectomy, and 2 cases we have given methotrexate. We can expect uncontrollable hemorrhage, which is very, very difficult to manage. So what are the options for the management? Medical management, dilatation and curettage, local prostaglandin injection, hysteroscopic resection can be done, angiographic uterine artery embolization, uterine artery ligation as complementary to the other treatment modalities, cervicotomy. There's not much literature in this, intracervical injections of vasoconstrictive agents, and Shirodka type of cerclage. So what are the medical management? We can give methotrexate. There is certain criteria. If the gestational age is less than 9 weeks without cardiac activity, I won't go into the detail of methotrexate treatment, as Kiran Pandey madam has explained it. And when are the failures seen with the single dose of methotrexate? When the gestational age is 9 weeks, more than 9 weeks, beta HCG is more than 10,000 milli international units, CRL is 10 millimeters, and if there is a presence of fetal cardiac activity. If methotrexate is unsuccessful, or if there is a torrential bleeding, we can do uterine artery embolization, which minimizes the risk, and we can do curettage. Woman has completed the family and she's having bleeding, definitely we can go for hysterectomy, and that is the main option. Minimally invasive, like giving the methotrexate and then going for hysteroscopy, is also one of the good options to conserve the uterus if the woman wants future fertility. The success rates with this is 55 to 83%. With cardiac pulsations, it is 40%. Without cardiac pulsations, it is 91%. So what are the complications that we can see? Heavy vaginal bleeding when the pregnancy is involuting may occur. How can we tackle this? Intra-arterial embolization to control bleeding. If this is not successful, we can do dilatation and evacuation, and hysterectomy is the last resort. Suppose we want to do the hysterectomy ablation of the ectopic gestation, definitely we can conserve the uterus in almost 80%. And the resolution and uterine preservation are achieved for gestations less than 12 weeks in 91% of the cases. That is what the evidence shows. In case of heavy bleeding or a severe hemorrhage, we can put 26F Foley catheter with 30 ml of balloon placed intracervically, and which remains for 24 to 48 hours, gradually decompressed over a few days. This is the cervical stitch. Before doing evacuation or a hysteroscopic resection, we can put the stitch to minimize the bleeding. Uterine artery embolization. So surgical management, dilatation and curettage is definitely favored in some cases. If there is sometimes the tissue, the placental tissue is not invading the myometrium, definitely dilatation and curettage can be done. So before doing dilatation and curettage, we can apply the stitch that we have shown, or something like a Shirodka stitch can be applied. Preoperative uterine artery embolization can be done to minimize the bleeding. There are very, very few cases which show cervicotomy helps, but it is a very difficult procedure, and better we do a hysterectomy in indicated cases. This is the hysterectomy specimen, which with the cervical pregnancy, where Rubin's criteria can be confirmed. So take home message is, so high degree of suspicion is important when the woman is in the reproductive age group and coming to us. We have to definitely do a speculum examination. If we are suspecting cervical pregnancy in speculum examination, definitely we have to do an ultrasound. Then we can suspect the pregnancy, early diagnosis, and manage the pregnancy. Always we have to individualize the case. It is rare, but we should never miss the diagnosis, and we should have the knowledge of managing the patient. Thank you so much.
Thank you, Dr.
I think, you know that, yeah, I just wanted to say one thing, Aruna, that the beta HCG levels should be less than 5,000, and then only the methotrexate actually works.
Yes, ma'am.
In
Yes,
more
the
than
literature says
5,000,
less
it
than
never
10,000.
works. Yeah,
Yes.
actually,
And
the
if there is
cutoff should be
cardiac activity,
5,000.
Yeah, okay. And
Right.
if there is cardiac activity, we have to put KCL into it. Then
Yeah.
after the baby dies, we have
Actually,
to
there
give
should
the
be no
methotrexate.
cardiac activity, and I have seen it work actually
Yes.
best if the beta HCG is around 3,3500 and below.
Okay.
Then it works beautifully, the methotrexate.
Yes. Yes, ma'am. In 2 cases, we have tried methotrexate, which worked very well. In 2 cases, we had to do hysterectomy.
But that is definitely a very tricky situation, cervical pregnancy.
Yes, ma'am. Thank you
So
for the
wonderful
opportunity,
program,
ma'am.
and we can.
Yeah.
Thank you, Dr. Aruna. Very nice presentation. Please answer the questions also. There are a few questions in the chat box. So now we
Okay.
quickly go on to the next topic, which is cesarean scar pregnancy, pathophysiology and clinical features. And the speaker is Dr. Kruti Deriwal. So now I request Dr. Ranjana Sharma ma'am to please introduce.
Ranjana Khanna, I'm
Sorry.
not Sharma. Please don't
I
change my
don't know.
caste at this
Sorry.
stage.
Dr. Ranjana Khanna ma'am, please introduce.
Yeah, can I have? Acha, haan, I've got her CV.
It's with you.
Dr. Kruti is Associate Professor,
Meantime,
SMT.
Kriti, you share your presentation.
Yeah.
I'm sure first
Yes.
slide will be your.
Yes, ma'am. Yes,
She's Associate Professor, SMT, NHL Municipal Medical College, SYP Hospital, Ahmedabad. So Kruti, please, you're welcome to give your presentation on cesarean scar pregnancy.
Thank you, ma'am.
So make it full
Good
screen.
evening. Yes, ma'am. Yes, I'm doing. Good evening, everybody. At the outset, I would like to thank to the chairpersons ICOG and Richa ma'am. Thank you so much, ma'am. Today's my topic is cesarean scar pregnancy, pathophysiology and clinical features. The first case of cesarean scar pregnancy was reported in 1978. And after that, the incidence of the CSP has been increasing, go on increasing. At present, the incidence reported are 1 into 1800 to 1 into 2200. Still more, it is expected to rise in the future in the cases of CSP. Why it is so? We have to think for it. It is increasing because the increase in the prevalence rate of the cesarean section. The cesarean section rate is almost double from the year 2005 to 2015. So as an obstetrician, we have to think to decrease the cesarean section rate. And one more thing is improve the diagnostic techniques. That is, the ultrasonography is now very good to diagnose the cesarean scar pregnancy. So also the incidence has been increased. What is the pathogenesis and risk factors of the CSP? Exact causes and mechanism are still unclear. The presence of the uterine scar lesions and small scar defects after the cesarean delivery is responsible for causing the CSP. Defects can also develop from the trauma of the other uterine surgeries like curettage, myomectomy, metroplasty, hysteroscopy, and even sometimes with the manual removal of the placenta. Information on any correlation between the number of the previous cesarean section, the indication of the cesarean section, whether it has been done in the elective or emergency cesarean section, surgical techniques applied, that correlation is still not known. This is the figure showing the uterine isthmosil. It is known as the niche. The hypoechoic area within the myometrium of the lower uterine segment reflecting the discontinuation of the myometrium at the site of the previous cesarean section scar is known as the niche. Patients of this niche will be present with the intermenstrual bleeding, postmenstrual bleeding, sometimes they can present with the secondary infertility. This is known as the cesarean scar syndrome. Evaluation of the niche should be done at least 3 months after the cesarean section, and the best time to evaluate is the post-menstrual period, when the endometrium has shed off and the blood collected in the niche can be seen very good. Regarding the pathophysiology, in some cases of the previous cesarean section scar, the scar is healed with the fibrosis at the cost of the myometrium, resulting in the formation of the niche. Also, sometimes there is absence of the decidua basalis or partial disruption of the nita bush layer will lead to the fibrinogen degeneration and is responsible for causing the CSP. Sometimes, due to the lack of the decidua, excessive tropoblastic invasion occurs into the muscles and serosa, and it leads to the scar ectopy. If it remains undiagnosed, it may continue as adherent placental syndrome. Usually, the patients are asymptomatic in 37% of the cases of the CSP. Sometimes, patient may present with the painless vaginal bleeding. In 9% of the patients, presence of abdominal pain is there. And in 16% of patients, they are presented with the vaginal bleeding and abdominal pain. If the patient present with the severe acute pain with profuse bleeding, one has to think for the impending rupture of the CSP. And if the patient is collapsed or hemodynamically unstable, then it strongly indicates the rupture of the CSP. Ultrasound is the primary diagnostic modality, and the transvaginal approach is the gold standard tool for the diagnosis of the CSP. MRI can be used as a second-line investigation. And the biochemical markers like beta-HCG, it has no role in the diagnosis of the CSP. So diagnosis could be made only ultrasound. If the person is doing the good ultrasound, they can diagnose the CSP. In the transvaginal sonography, there are the criteria to diagnose the CSP. Madam has already showed the slide in the previous presentation. In patients of CSP, the uterine cavity is empty, endocervical canal is empty, gestational sac is located anteriorly. At the level of the internal os, it is embedded at the site of the previous lower segment scar. The myometrium is very thin or absent and seen in between the gestational sac and the bladder. Regarding the role of the Doppler, prominent tropoblastic or placental circulation can be picked up in the Doppler examination with the patients of CSP. This is the figure which shows the lower pregnancy located in the lower uterine segment and the CSP. If the pregnancy is located in the lower uterine segment, we can see the demarcated line between the niche and the pregnancy. So one has to think for the pregnancy in the low implanted pregnancy in these cases. This is the figure which helps in the diagnosis of the cesarean scar pregnancy. We have to draw two lines. One is parallel to the endometrial cavity and other line is drawn parallel to the serosal line. If the pregnancy is located in between two lines, then one has to think for the cesarean scar pregnancy. According to this classification, it has been classified in the two types. Type 1 is the endogenous CSP. In this, there is superficial implantation of the embryo on the cesarean scar, and it develops towards the cervicoischemic space or the uterine cavity. And in type 2, it is the exogenous CSP. Here, the deep implantation of the embryo into the cesarean scar defect, growing towards the bladder, infiltrating the uterine myometrium, and it bulged towards the uterine serosa. This is the graphical as well as the sonographic picturization of the things which I have mentioned. Figure A shows the endogenous pregnancy. In this, the pregnancy goes towards the uterine cavity. Figure E shows the exogenous exogenous cesarean scar pregnancy. In this, the pregnancy grows more towards the serosal layer, and in between, sometimes CSP could be seen in between. That is according to the figure C. So, what is important when the patient is non-pregnant, and if you see the niche is present, then one has to see the myometrial thickness besides the niche and at the level of the niche. From that, you can diagnose how big is the niche and what is the possibility of this patient to develop the CSP in the next pregnancy. So this is very important if the patient is presented with any of the syndromes or the premenstrual bleeding. So there is one Delphi consensus survey has been done regarding the patients of the previous cesarean section. If they got pregnant, then the basic evaluation should be done in the sagittal plane, and one has to see for the location of the gestational sac, location of the placenta in relation to the uterine scar, whether the placenta previa is present or not, and placental or the tropoblastic invasion into the myometrium niche is present or not. All these criteria will help us to diagnose the CSP at the earlier stage. So this is the algorithm showing if the patient is pregnant with the history of the previous cesarean section, then one has to do the first trimester sonography, and one has to proceed to according to this algorithm. If it is the intrauterine normal pregnancy, follow-up scan is done for the placentation. If you think it is the near cesarean scar or the cervical pregnancy, you have to go accordingly. The management will be discussed by my next speaker. So take-home message is double layer uterine closure with non-locking sutures will result in the thick myometrium and decrease the prevalence of the niche. Symptomatic niche should be managed surgically to avoid the possibility of the CSP or past disorders. CSP is the definite precursor of the past disorders. It is always advisable to carry out the transvaginal sonography to evaluate the pregnancy at the earlier age, especially in the patient with the previous cesarean section. It is always better to manage the first trimester CSP rather than to progress towards the past disorder at the advanced gestational age. Thank you so much.
Thank you, Dr. Kruti. Very nice presentation. So I just want to tell all the audience and the delegates, like the abortions, what we are discussing today, that is ectopic pregnancy, cervical, cesarean scar pregnancy, molar. So these are not covered under the MTP Act. So you don't have to fill all the documents like consent form C and form 1, 2 or 3. You don't have to fill. Even for incomplete abortion, missed abortion, you don't have to fill. So MTP is the termination of pregnancy of a normally localized and live pregnancy. So that has to be kept in mind. That is one thing. And regarding the ultrasound, ultrasound is not mandatory, not a basic investigation before we do MTP, but still you have to correlate with your clinical findings, and especially the early gestation and also the previous cesarean scars. It is very important to rule out the scar ectopics or the ectopic pregnancy in early gestation, because MTP is governed by the Act. So we have to be careful in each and every aspect. That's why we covered all these abortions in day 2. So it has to have the clarity between everything. So thank you, Kruti. And
yeah, but I think that if there is a history of previous cesarean, then it is almost mandatory to do a ultrasound before we proceed for an evacuation.
Yes. So now we move on to the next topic. That is a very important topic. That is cesarean scar pregnancy management. That is by Dr. T. Ramani Devi, madam. And can I request Dr. Sangeeta Jogi to please introduce her?
Yeah, good evening, everyone. It's my pleasure to introduce Dr. Ramanna Devi, madam. We all know her very well. She is.
Devi, you can share your screen. I'm sure first slide.
Yeah, I am just trying to share my screen.
Yeah.
She was the National Vice President FOGSI 2020, International Advisory Board member of Fertility Society of Bangladesh, and editor and peer reviewer of so many journals and recipient of so many awards. So it's our pleasure to have you here, ma'am. And she will be speak on cesarean scar pregnancy and its management. Dr. Ramanna Devi, madam, please.
Yes, just 1 second.
Ramani Devi. Yeah.
Ramani Devi.
Yeah, is Ramani Devi. Yeah, please share your screen.
Yeah, just.
Yes. Ramani, are you with us?
Yes, I am very well with you.
Because we can't see
Just
your
one
screen.
second.
Yeah, yeah.
I
Your
got some.
Yeah, yeah.
Yeah. It has come. Don't worry.
Yeah, it is coming.
Okay.
Yeah. Great.
So let me start my presentation with the case scenario. Mrs. M, age 26 years,
Slides are not
came
moving.
to
You have to move the slide.
hospital with history of 45 days of amenorrhea.
Yeah, please.
It's seen, no slides? Is it moving?
Case
Okay,
study
so
slide.
let me start the presentation with a case study where a 26-year-old lady came with a history of 45 days of amenorrhea for good, stable, case study slide. Are you able to see?
Yes, Ravi.
Okay. So she was a gravida 3, actually one previous LSCS, one tubal ectopic pregnancy, which was medically managed, and all the 2 had happened in our own center. Ultrasound showed no intrauterine sac, and there was no adnexial mass also. So now how to follow? Once when we don't see anything, then we have to go for a beta HCG, which was found to be 6,418 milliunits. That means she has to have a sac somewhere. Okay, then repeat HCG was seen. This was a small tiny sac that was seen on 31/12. But after 9 days, when we repeated, her beta HCG has gone up, but not to the expected level as it would be in an intrauterine pregnancy. Okay, so this was an ultrasound where you can see a scar site ectopic pregnancy, and the cervix is clearly seen down below, and you can see the entire intrauterine cavity with the decidual changes. So this shows that this is probably a case of scar site ectopic pregnancy. So uterine cavity, cervical canal, everything was normal. So this is another patient where she had a twin ectopic sac in the previous cesarean section scar. Okay, so this also you can see, just for the interesting thing, I had posted this. So then in the previous case, there was only yolk sac was seen. There was no fetal pole. Chorionic decidual reaction was very good with a good vascularity. So now how we are going to manage? Patient was started on conservatively with 2 doses of methotrexate injection, 50 milligram per day on alternate days, and after 7 days, repeat scan showed persistent sac with no fetal heart rate and reduced vascularity. So hence we kept misoprost 200 micrograms vaginally and then repeated after 4 hours, and the patient did not expel the products of conception. So after that, we went for prostaglandin F2 alpha 125 micrograms was given 2 doses at 1 hour gap, and she expelled the products partially, but still the ultrasound showed some reading. We went ahead the viscopy done. There was no bleeding and the procedure uterus. So this was the histoscopy. As you are coming down in the anterior uterine wall at the level of the previous scar, you can see the beautifully placed products of conception are quite very well seen. That yellowish thing you can see. And then this was after the curettage, gently under the laparoscopic histoscopic guidance, the curettage was done. And this was the histoscopic view that was seen after the complete curettage. And the repeat ultrasonogram was a normal uterus. Okay, then. So overall, how you are going to manage the pregnancy? Scar site ectopic pregnancy. First one is expectant management, which is very, very rare and which has got the highest complication. Next comes the medical management, and third comes the surgical management, and a combination of other types of management. So the medical management includes commonly used drugs like methotrexate or local injection of any of the embryocytes like methotrexate or KCL or hypertonic dextrose, and combined medical management. Either this can be combined with any other medical management, or it can be combined with surgical sac aspiration like how we have done in our patient. Then comes the surgical management where uterine curettage. I don't believe in uterine curettage because the sac is well below the uterine level. Histoscopic evacuation, laparoscopic removal, primary open surgery, and hysterectomy. So the others are we can combine with a high intensity focused ultrasound ablation, and then again, we can go in for an uterine artery embolization prior to surgical management. So the expectant management, according to the ACOG and many other literature evidence, there are more than 30 different treatment modalities with variable success rates, with variable morbidity and mortality. Everything depends upon the patient's stability, desire for future fertility, and extensive counseling is needed. And we have to tell them about the morbidities and desire for future fertility, but still we don't have definite consensus for the treatment approach. So these are all what I have said for all the previous slide. What I have shown is for the expected management, and there are definite contraindications for expectant management, like first line, it has got a high degree of high likelihood chances for hysterectomy, and we need a complete close surveillance and the poor outcome and a higher failure rate requiring additional intervention as surgery. So I think the slides are jumbled up, sorry. So this should be the expectant management, and after that comes the contraindications. Okay, so when the patient wishes to have a top and wants whether she wants to continue the pregnancy, it all depends. See, my previous speaker has very well mentioned that there is exogenic and endogenic types of the endogenic scar, maybe endogenic implantation, probably where the fetus goes inside the uterine cavity. We can expect management, and delivery to be done by 28 to 30 with a proper prenatal antenatal corticosteroid administration. But the efficacy is very low, complications are very high, and the patient can have placental complications. So the complications are greater than 50% of the patients. They can have hysterectomy, preterm delivery, uterine rupture,
your voice is breaking.
Fertility may be affected, significant hemorrhage, and maternal death in ruptured ectopic pregnancies can happen. So going into the surrounding organs. Okay, I'll come closer. Okay, hemorrhage, DI1, death. So next, coming to medical management. So it is not that management should be reserved at high, setup. Okay, then coming to the medical management, it can be systemic or local, systemic methotrexate, or a local injection of embryocytes, or combined medical management, or combined surgical management. So the common drug that is used is 50 milligram per meter squared of dose of methotrexate that should be given IM, and depends upon the level of the serum beta HCG. Either one shot is enough, or we can go for multiple shots. And preferably, the criteria should be the patient should be hemodynamically stable without pain, and the gestational age should be less than 8 weeks. And the myometrial thickness is very important. If it is less than 2 millimeter between the pregnancy and the bladder, maybe in a smaller condition, in a smaller gestational age, we can go for methotrexate injection, and the complication rate is around 13%. So next, coming to the medical management, there was a very good scoring model. Who should undergo medical management? Based upon the gestational age, less than 6, 1 score, 6 to 8, 2 score, greater than 8, it is 3. Abdominal pain should be absent or present, it may be 1 or 3. Beta HCG level less than 3000, it is 1. More than 10,000, it is 3. And in between, it comes 2. And the gestational, accordingly, gestational sac measurement. So the rates of conversion to surgical treatment depends upon the score. Like, for example, if the score is less than 6, then there is 100% chance the patient can go in for a medical management. 7 to 8, it may be 15% chance that they can go for a surgical management. And if it is more than 9, nearly 50% of the patients will need surgical management. Then the combination of embryocytes, what are the local injections that are available? As I have said earlier, methotrexate, potassium chloride, hyperosmolar glucose, and crystalline trichoxanthin have been used for termination of cesarean scar pregnancy. But the commonly preferred agent is methotrexate, which can be injected under ultrasound guided. It can be introduced into the gestational sac via trans-abdominal or transvaginal route. I think here I would rather prefer using a transvaginal route. The double lumen oocyte retrieval catheter needle can be pushed in, and through the ultrasound guidance, we can inject the methotrexate. Then a combination of medical thing is other things is you can give local injection of potassium chloride followed by 60 milligram of methotrexate injected into the gestational sac, or it can be 3 ml of 50% glucose plus oral methotrexate, or cervical injection of crystalline trichoxanthine can be injected, followed by oral mifepristone, and then later intramuscular methotrexate or systemic methotrexate that can follow, followed by oral. So like similar to any other technique of abortion in intrauterine pregnancy, misoprostol followed by this mifeprine followed by misoprostol can be used. So again, when should you combine it with the surgical management? So you can, as I have said in the case study, we can say that it should be followed by potassium chloride and systemic methotrexate transvaginal guided sac aspiration, and after the sac aspiration, then we can give the vaginal route can be sac can be aspirated after the local methotrexate, and ultrasound guided DNC or hysteroscopic guided DNC can be done. So intrauterine curettage is being repeatedly mentioned in all the case reports. But I find this uterine curettage is obsolete. It should be obsolete because the sac is only at the lower level, and that suction curettage has to be done under ultrasound guidance. And similarly, when you find any difficulties, that is, it is always preferable to reduce the vascularity, then you go for ultrasound guided dilatation and curettage can be done. And maybe in cases of severe bleeding, local injection of vasopressin or intrauterine balloon tamponade or bilateral uterine artery embolization may be required. If facilities are available, probably balloon can be introduced, and in the event of any bleeding, it can and immediately uterine artery embolization can be done. So all these things, the complications of medical management are significant hemorrhage and the need for the surgical intervention, and all the adverse effects due to methotrexate when they are used in multiple doses can happen. Otherwise, 1 or 2 doses is not going to have any impact. Then comes the surgical management. Here, hysteroscopic evacuation, like how I showed you. Then laparoscopic removal can be done, or primary through the laparotomy, or ultimately the hysterectomy could be done. So in hysteroscopy, it can be done alone or with the adjuvant medical therapy. So the hysteroscopic removal of the tissue, aspiration of the gestational sac after medication, injection of methotrexate or ethanol into the gestational sac can be done. So all these things are ideal in type 1 CSE, that is type 1 cesarean scar ectopic pregnancy. And the results are highly variable, and requirement may be additional procedures may be needed, including hysterectomy. So the hysteroscopic evacuation, there was a successful treatment by hysteroscopy that was mentioned by Chang et al. In the year 2005, where the gestational sac, you can see this in this picture. This is not a video, but what I had showed, we had showed clearly the products of conception. So it can be finally removed. DNC could be done under the hysteroscopy, and then finally, if you find any evidence of bleeding, it could be cauterized using a roller ball cautery. So post-operative, sometimes if the bleeding persists, we can introduce a balloon catheter. According to ASRM 2016, hysteroscopy could be used to remove cesarean scar ectopic pregnancy via direct visualization of with ultrasound assistance. Dissection of CSEP from the uterine wall using electrosurgery. Electrosurgical methods had the highest success rate, extremely low complication, and should be considered safe and effective. And the complications are rare, and fluid overload and electrolyte imbalance, perforation, infection, and hospital admission are rarely. Probably it could be done as a daycare procedure. And one important point I would suggest is when the material thickness is beyond 3 millimeters in patients go because there will not be any, depending upon the procedure, a lower earlier gestational age at the time of procedure. Okay, then finally, laparoscopy. Laparoscopy is suited ideally in type 2 cesarean scar ectopic pregnancy, where laparoscopic hysterectomy should be done with a wedge resection, I can show you a beautiful video what I got from Dr. Alka Kriplani. It is found to be the best because it is minimally invasive, where we can directly visualize the pregnancy, remove the scar with a very good success rate and a very good subsequent pregnancy rate. So this is what the picture, and then prior to, this is a beautiful laparoscopic picture where you see the cesarean scar ectopic here. Injection of vasopressin prior to the dissection will devascularize everything, and then it will be so you can beautifully separate the previous C-section scar. The bladder can be pushed down, and then you can dissect laterally, and you can identify everything. And in the lower previous C-section scar, you can put in the cautery, or by a direct scissors, we can actually remove the ectopic sac from all the sides. And then very beautifully, you can remove everything. Once when every bit of this products of consumption is removed, you can refresh the edges so that the scar will not be thin, and then you can insert a uterine sound, which will help to bridge the cervical gap on the lower uterine segment. And again, you can suture it in again in 2 layers with the perfect suturing could be done. So this will not create a weak scar in the subsequent pregnancy. Okay. So then comes the vaginal approach. This has been reported in literature in 2017. That is basically the anterior vaginal wall should be opened as we do it in a case of non-descent vaginal hysterectomy. And when you push the bladder, you can see the ectopic scar lying at the lower uterine segment. And this we could apply some vasopressin, and then you can excise it with from the vaginal root, and then resuture it. This can be done in stable patients who desire future fertility. Advantageous morbidity is less, and success rate is around 90%. And then this can again be combined with uterine artery embolization. So that will reduce the amount of bleeding. Okay, then ultimately, when the mass is quite large, when the ectopic cesarean ectopic pregnancy is quite large, don't worry, you have to go ahead with the laparotomy, and or when uterine rupture is being confirmed, laparotomy is the only way. And here again, there is a high chance of abnormal placentations like placenta accreta. So this has to be carefully watched, and we have to plan our treatment and by imaging technology, whether the patient has got a placenta accreta, and then go accordingly. See here again, uterine artery embolization prior or uterine artery ligation at the time of laparotomy can help to minimize the amount of bleeding. So the guidelines for laparotomy are not considered as the first line, but it should be avoided in cesarean scar ectopic pregnancy if management is possible. But when there is potential morbidity to the bladder or the urethra, or likely chances of bladder involvement, or if you think there may be some problem, then there is no doubt that we can go for a laparotomy. And then, but definitely we know the longer duration of stay and the morbidity, operating time, and there will be a slower return to the normal activity. So ultimately, the last one is hysterectomy, which is always not advised as a primary procedure, except in cases of intractable hemorrhage due to rupture. So that is once when we do a laparotomy, when the hemorrhage is intractable, ideally hysterectomy should be done too, and early dissection should be made. So the combination approaches, either they can combine with uterine artery embolization or histoscopy or laparoscopy, needle aspiration. All these things will give a success rate of around 80% in a earlier pregnancy, not in advanced stages. So then other treatments that are available are repeated high intensity focused ultrasound ablation, which can destroy the diseased tissue by coagulative necrosis. And this novel modality treatment was only described in one high quality series of 16 women who have undergone the treatment. Of course, we do come across certain complications in that. Other modality is you combine high intensity focused ultrasound with hysteroscopic suction curettage, because that high intensity focused ultrasound will reduce the bleeding and then it can be followed by hysteroscopic suction curettage. So there was a study where series of 53 women with a success rate of 100% without any complications. So last one is uterine artery embolization. If facilities are available, better you undergo, take it, and it should be undertaken in selected cases when you think that there is AV malformation or when there is a significant bleeding. So these are all various modalities of treatments with the different rates of success rates, complication, role of how many had undergone hysterectomy with a blood transfusion. And next is, this is again the author, Peng et al. Zhuang. Yeah, almost all of them are Chinese studies where they have had the high number of cases, and the primary treatment was either methotrexate or uterine DNC, and then hysteroscopic, and so the gestational age is given here with the success rate, and finally the complication rates are given. So the future pregnancy, what will happen? Uneventful future pregnancies have been reported after all modalities of conservative management. And the largest study shows that 50% of cesarean scar pregnancies were followed by uneventful pregnancy with a mean interval of 13.3 months between the previous CSP and the subsequent pregnancy. Risk of recurrence is still there, 3.2 to 5%. And once if the patient has got a previous cesarean scar ectopic pregnancy, it is always mind that the patient should undergo a very early ultrasound to confirm whether the sac is intrauterine or again in a ectopic site. So the conclusions are embryo implantation in the region of previous cesarean section scar is very rare, but it is potentially catastrophic complications can happen. Exponential rise in the C-section rate has also increased the incidence of cesarean scar ectopic. Diagnosis is by transvaginal ultrasound and color Doppler can help, and OCAL, the 3D ultrasonogram with the color mapping, can even pick up better in a better way, where avoiding the MRIs, and there are plethora of modalities available and there are no guidelines, but we should choose early ultrasound to pick up the lesion, and combination of medical and surgical management is the next option. Surgical management is preferable only in advanced stages like laparoscopic or laparotomic excision of this cesarean scar ectopic. Always think about the complications and counsel the patients. In severe cases, hysterectomy may be the option. I thanks the ICOG, Richa Sharma and Dr. Lakshmi Srikande for giving me this opportunity to say a few words about the management of cesarean scar ectopic. And we had 3 patients with C-section ectopic pregnancy, and all the patients were managed only conservatively because we had identified them within 6 to 8 weeks. Thank you.
Ramani, it was an overview in detail, not few words. You have taught ABCD, A to Z. Fantastic talk. Please answer all the queries in the chat box before you leave.
Okay.
Richa, let's invite another speaker. Yeah.
Thank you, Ramani madam. It was an excellent presentation and you covered every aspect of it. And you really have a good collection of cases.
Thank you.
Thank you so much.
Thank you.
So now we proceed on to the next topic, that is molar pregnancy treatment and follow-up by Dr. Abha Singh. So now I request Dr. Aarti to please introduce her.
Yeah, let Abha share her screen, and first slide is her intro slide. Yeah. Next slide, Dr. Abha. Yeah.
May I take the pleasure to invite Dr. Abha Singh Madam, who is a director and professor at Lady Hardinge Medical College and Kiplani Hospital. He has been the past president of AOGD, past president of NARGI, and multiple accolades to her name. She's been the chairperson of Safe Motherhood Committee in the past. May I please invite ma'am to take deliver the lecture on molar pregnancy treatment and follow-up.
Good afternoon, everybody. So today, let me at the outset, I should thank
Dr. Abha, can you speak a bit louder because your volume is low? Just either increase or come closer to the speaker, please.
So
yeah, better.
It's okay. Okay. So at the outset, I'd like to thank Dr. Lakshmi and Dr. Richa for giving me this chance, and I'd like to thank Dr. Pai and Dr. for giving us this opportunity today. And without wasting any time, I'll go to my topic, that is hydatiform mole. This is also known as vesicular mole. What is a H mole, a hydatiform mole? It is abnormal conception resulting in hydropic, it's running, the slides, of the chorionic villi and trophoblastic proliferation leading to formation of grape-like vesicles. So it was first described by Hippocrates around 400 BC as dropsy of the uterus. It is a benign neoplasia of the chorion with malignant potential. So that is why it is important, this terminology, hydatiform mole. It is actually a benign condition, but it has the malignant potential. And in the incidence in the US is around 1 to 2 in 1,000 pregnancies, while in India it is 1 in 400 pregnancies. So again, you can understand that the magnitude is too much in India. Then how many types of mole we know about? A complete mole and a partial mole. There's another terminology known as gestational trophoblastic disease. So this is another terminology in which it includes a spectrum of abnormal proliferation of trophoblastic tissue associated with pregnancy. And here again, we can have complete mole and a partial mole, and non-molar tumors are included in this, or gestation trophoblastic neoplasia, which has been defined by Figo in 2002. One is invasive mole, the other is choriocarcinoma, and third is the placental site trophoblastic tumor. So I'm not going to discuss all these. Know the pathogenesis of molar pregnancy. Normal pregnancy, what happens? One ovum and one sperm, it combines and forms the zygote, and here there are 46 set of chromosomes. While in complete mole, what happens? The ovum, it is, and it does not have a nucleus. It is anuclear ovum with a sperm which has 26 X chromosomes. And here what happens? This there's mitosis, the 46XX of this paternal chromosomes multiplies. So what happens? There is no female chromosome, so the fetus is not formed. While in partial mole, what happens? The ovum is there, 23X, and 2 sperms are fusing. So what happens? The number of chromosomes, it becomes 69, 69XXY or 69XXX. So that is why there may be presence of the fetus along with the vesicular changes in the placenta. So what is the difference between complete and partial mole? This is important to tell you because this is how we will manage the patient also. In complete mole, there is a molar gestation, while in partial mole, you may just find a missed abortion. The size of the uterus is more than 50% as according to the dates of the patient, while in partial mole, it is smaller than period of gestation. The medical complications are more frequently found in complete mole, like preeclampsia, then thyrotoxicosis. All these things are more common, while it is rare in a partial mole. Theca leucanthus are present in complete mole, 25 to 30% of them will have it. Then gestational trophoblastic neoplasia. This is found in 15% in complete mole as compared to 0.5% in partial mole. So that is why there's a need of chemotherapy in 15% of these complete moles. And the pathology, you find that the fetal tissue is absent. The fetal tissue is absent in the complete mole, as well as amnion is not there. While in partial mole, you will sometimes find a small fetus or a growth restricted fetus is present along with the amnion. And the villus, there will be villus edema, which is diffuse in complete mole, while it is variable or just focal in partial mole. Then trophoblastic proliferation is variable to slight in complete mole, while in partial mole, it is usually focal or slight. And the chromosomal pattern, I've already told you, is 46X here, while it is 69XXX or 69XXX. And the HCG values, they are markedly increased in complete mole as compared to a partial mole. The etiology, I will not go into detail. The maternal age at the extremes of reproductive age group, then Asians, previous molar pregnancy, it is 10 times. If after one previous mole, the chances is 1 to 2%. This is supposed to be 10 times higher than a normal pregnancy. And after 2 moles, the risk of getting a molar pregnancy is 15 to 28%. So that is why it is really important. And the other risk factors are nutrition, cytogenic abnormalities, and other factors like smoking, use of OCP pills have all been associated. Then the complete mole. In the complete mole, we find that the fetus is replaced, the whole uterus. This is the uterus, and it is all filled with these vesicle-like structures inside, which are the villi, edematous villi of fluid-filled villi in the uterus. And this lacks the blood vessels. So usually you don't have too much of bleeding. Then in partial mole, you may find a small fetus, and sometimes you find the vesicular changes in the placenta also. Then the signs and symptoms, I know you are all aware, I should not go into details, slight amount of bleeding or maybe passage of vesicles, patient may be having nausea, vomiting. So all these things may be present, and there may be pressure, pelvic pressure or pain, and the size of the uterus has grown beyond too much beyond the period of gestation, maybe double the size. Then preeclampsia, the features of preeclampsia are present, anemia, hyperemesis gravidarum, and features of thyrotoxicosis are present. Investigations which you should be doing is complete blood grouping, and RH, because if you want to, if the patient is RH negative, you have to give anti-G afterwards. Then LFT, KFT, and TSH. Again, TSH is very important. In ultrasound, again, in a complete mole, you will find snowstorm appearance. That is, the whole uterus or the whole cavity is filled with small hypoechoic areas with hyperechoic areas in between, and there is no gestational sac, no fluid-filled cavity, nothing like that, and no fetus is there. While theca luteins are usually present. In partial mole, there may be some fetal tissue, and there may be cystic dilatation of the placenta at some places. Then urine pregnancy test will be positive, beta HCG. If you do HCG in the urine, again, that will be high. Beta HCG, again, it will be more than 1 lakh ml, milli international units per ml. An X-ray test should be done. Ideally, we don't expect anything, but you have to see for pulmonary embolization. These small vesicles, if they go into the pulmonary circulation, they will be present in the lungs. But this is not a sign of metastasis. And once this vesicular mole is evacuated, these vesicles from this lung circulation will also disappear. Then again, you should rule out lung metastasis at that stage also. Then after evacuation, you should send the tissue for histopathology. CT and MRI, they are not required at all. And only you can do it if you suspect there's perforation or you have suspected that there is metastasis. Now we come to the treat. The treatment is again supportive, that is, start IV infusion, arrange for blood, at least 2 units of blood, start broad spectrum antibiotics, and then the definitive treatment is evacuation. That is, if the os is open, you can do a gentle evacuation of the cavity by using a plastic suction cannula number 10 or 12 for evacuation. While if the os is closed, that is, the patient is not in a process of expulsion, she is not gone into labor or into process of abortion, then you need cervical dilating agents like misoprostol can be used, dinoproston or laminaria tens as we used to have earlier, that can also be used. Then another thing is, how are you going to evacuate? Earlier, if you remember, our old people will be knowing that we used to use injection oxytocin drip. You used to put 20 units of oxytocin in the drip before we started evacuation. But now the RCOG has said in 2010 that don't use oxytocin drip because they are at risk of tumor embolization. So you can use the dilating agents and do a gentle suction evacuation just by the plastic suction cannula. Don't use the metallic cannula also. I think this generation may not have seen the metallic cannula, but earlier we used to use the metallic cannula. The complications with metallic cannula were more chances of perforation. So nowadays plastic cannula are available. And another thing is, after doing the process is over, you can give methogen to contract the uterus and prevent blood loss. If bleeding is present, you can give IV drip with 20 units of oxytocin at the rate of 20 to 24 drops per minute. Another thing is, earlier we used to do curettage of the cavity after completing the evacuation. Now they have said that after evacuation by suction, you don't have to do a curettage because there are more risk of perforation, more risk of the tissue going. So that is why it is not advisable, but if you require it for any instance, you can do it after 5 to 7 days, not immediately, because risk of perforation is higher. Then the complications associated with evacuation are hemorrhage, sepsis, perforation, presence of preeclampsia. So these are the complications which are associated. And curettage after evacuation is required. If required, should be done after 5 to 7 days. And the evacuated tissue, it should be kept in formalin, 10% formalin, and sent for histopathology. And if the patient is Rh negative, then you have to give anti-D post-evacuation. Then another thing is role of hysterectomy. So ideally, hysterectomy is not required, but in patients who have intractable bleeding, age is more than 40 years, patient has completed a family, there is suspicion of perforating mole and or placental site trophoblastic tumor, then you should go ahead with hysterectomy. Then what are the investigations you should do? How will you follow up this patient? So what investigations you should do? That is incomplete mole. If HCG levels fall to normal within 8 weeks, usually in complete mole, they fall to this normal level in 9 weeks, while in partial mole, they come back to in 7 weeks. So if HCG levels fall to normal within 56 days or 8 weeks, monitoring is done for 6 months from date of first normal blood sample. So this is for complete mole, while in a partial mole, which has been confirmed after histopathology, you can do urine and serum HCG every 2 weeks until HCG levels are normal. And this will be followed by one confirmatory normal urine sample after 4 weeks. This is the guidelines of some institution which I've just quoted, but we are usually monitoring with serum beta HCGs. And avoid pregnancy till the end of follow-up period, which is at least 1 year after you have evacuated the mole. So follow-up is required for at least 1 year or at least 6 months to pick up non-metastatic and metastatic cases which require chemotherapy. Then prevent pregnancy for at least 6 months, and because if the patient gets pregnant in between, you will there will be increase in HCG levels, and you will get confused whether this patient is having a new pregnancy or it is going towards resistant mole or persistent mole. Then the patient can be given OCP pills, and pregnancy can be avoided. Baseline beta HCG should be done before evacuation. Then after evacuation, that is after 48 hours, you should do a HCG level, and the level should come down by at least 10% when you do it after 7 days. And then you have to do weekly till 3 months. Then levels become negative in 9 weeks in a complete mole, while in 7 weeks in a partial mole. Baseline X-ray, I've already told you, should be doing to exclude chest metastasis and for future compliance. Then complications. Then at each visit, you have to ask the patient about the regularity of the period, whether the period's bleeding is irregular or she's having irregular PV bleeding, or she's having cough, hemoptysis, or dyspnea. This will tell you about the metastasis to the lungs. Then clinical examination should be done at each visit. for the size of the uterus, presence of ovarian cyst, and suburethral metastasis. You can see a bluish nodule below the urethra. So that ultrasound can be done to see the size of the uterus and the ovarian cyst, whether they are regressing, and what is the size of the uterus, what are the contents, whether the mass is increasing in size. Then chemotherapy. Routine prophylactic chemotherapy is not required in patients of a complete mole, because 80 to 85% will regress completely, while 15% with complete mole and 1% with partial mole pregnancy, they require treatment with chemotherapeutic agents. The indications of chemotherapy are high levels of HCG for more than 4 weeks post-evacuation, urine HCG more than 30,000 international units per 24 hours, or serum HCG more than 20,000 IU in 24 hours. Rising HCG levels or plateauing of HCG levels. Then heavy vaginal bleeding, which by which you can suspect invasive mole or choriocarcinoma, evidence of choriocarcinoma on histopathology, evidence of metastasis, or the hormonal follow-up is unreliable. The patient has gone to a village and she does not have the facility of doing the HCG levels, or the patient is a very high-risk patient of complete mole. So in those cases, you can think of giving chemotherapy. Otherwise, chemotherapy is not required in all the cases. Then the regimens are that you have to give methotrexate 1 milligram per kg body weight intramuscular, which comes down to, say, you can say 50 milligrams. The weight of the patient is around 50 kg, which we assume she may be more in the weight. So that is why we have to say 1 milligram per kg body weight, and has to be given on day 1, 3, 5, and 7 with folinic acid 0.1 milligram per kg IM on day 2, 4, 6, and 8. This will reduce the complication, and the total dose course is for 3 courses have to be given at interval of 2 weeks. So beta HCG should be done on day 4, and there should be decrease in 15%, and on day 7 again it should be done after methotrexate. Then alternative treatment is, if the patient is not responding or she is having some allergy or problems with methotrexate, she can be given injection actinomycin D 12 micrograms per kg body weight IV for 5 doses. This is supposed to be less toxic, and follow-up is required as there is increased risk of choriocarcinoma. So if you think that the patient is not responding to your methotrexate, then after calculating the risk of the patient, you can put her on imaco regime. This is intensive chemotherapy, which can be started in if beta HCG is plateauing or it is more than, or it is increasing. Then future pregnancy is not advisable till the HCG levels have been normal for 1 year. Risk of future molar pregnancy is low, but after delivery of the baby, HCG should be done to exclude the.
Sorry to interrupt.
Contraception.
But please finish early.
Contraception, OCP pills can be started after beta HCG level becomes normal. Injectable progestogens, that is DMP, is safe. Sterilization can be safely performed. IUCDs should be avoided because of risk of bleeding, perforation, and infection. Barrier methods can be given till beta HCG levels revert to normal. Then the prognosis, follow-up, I've already told you, early detection of persistent trophoblastic disease is the aim of follow-up, and prognosis is in mortality from molar pregnancy is almost 0. Spontaneous regression occurs in 80% of the molar cases, 20% develop GTN, and it is characterized by increase or plateauing of the beta HCG. Risk of recurrence is 1 in 4% of the cases. And after chemotherapy, the risk of congenital malformation in the fetus is not there. So she can conceive after the course of her chemotherapy. So thank you, everybody. for your patient hearing, and I'd like to give any answers if they're there in the chat box.
In the chat box, you can answer.
Okay.
Yeah, it was an excellent talk. Let's start our panel discussion, Kruti.
Okay. So
thank you.
Thank you, Dr. Abha. Now we go on to the next. Actually, it's a short presentation on complications of MTP, diagnosis and management. So we have divided into two short talks to the point algorithms. So first one will be covered by Dr. Sheila Mane, madam. She will be speaking on failed MTP and hemorrhage. So can I request Dr. Ashwani Balarao Gandhi, madam, to please introduce Dr. Sheila Mane?
Ma'am, please
Yeah, madam, you can share your screen.
unmute, ma'am. Ashwini, madam, please unmute yourself.
Yes. So it is my proud privilege to introduce Dr. Sheila Mane. She is ICOG Governing Council member.
Dr. Abha, please stop your screen sharing.
And
So Dr.
also
Sheila,
Vice Chairman elect of ICOG.
Dr. Sheila, please start your screen sharing. Yeah.
She is DNB faculty at KCG Hospital, Bengaluru at present. And she has been Vice President of FOGSI in 2014. And today her topic is failed MTP and hemorrhage, which are very common complications of MTP. Dr. Sheila Mane, you can start your lecture.
Can you see my screen?
Yes, we can see.
But I think the last slide is seen, I think.
Thank you is seen.
Thank you, slide
Yeah.
we have seen.
Yeah. Just a minute. Yeah.
Yes.
So thank you, Lakshmi, for the opportunity, and I must congratulate you for this initiative, because it is really, really very, very important. So I have to make a slideshow of this.
Yes,
Right.
yes.
Thank you, and thank you, Dr. Ashwini, for a kind introduction. So failed medical termination of pregnancy. First, I will talk about medical and then surgical. Now, when do you call it as a failed medical termination? Failed MTP is defined when there is a failure to achieve the termination of pregnancy within 48 hours after completion of medical method of evacuation. Now, there are parameters for assessing the failure. Yes, first is the clinical impression, because usually we tell the patient, that she has to observe that she has passed the products of conception. Clinical impression, bimanual pelvic examination, serial beta HCG monitoring, that will help if we have done it earlier, and transvaginal ultrasonography study with endometrial thickness, and a single post-procedure measurement of beta HCG, and a relative ratio of 2 measurements of beta HCG before and after the procedure. Now, why do we talk about failure? Because there are certain risk factors, and the risk factors are old age, multiparity, multigravida, previous spontaneous abortion, earlier follow-up, very early pregnancy, marked uterine anteversion or retroversion, uterine anomaly, undiagnosed ectopic pregnancy, because we will call it as, we will think that the MTP has failed, but there could be an ectopic pregnancy, and it could be even a scar pregnancy and fetal anomalies. Now, the first trimester, up to 9 weeks of pregnancy, the medical management is allowed. The dosage you people have already learned, followed, that is MIFI 200 mg after 48 hours, followed by misoprostol, 800 microgram vaginal or 600 microgram sublingual. And bleeding starts within 4 to 6 hours. Now, the recent guideline says that sublingual is better than vaginal. Now, if no bleeding with 6 hours, reassess clinically or bedside USG and proceed with manual vacuum aspiration. That means Government of India direction is, if the patient is educated, you have explained her everything, it's a very early pregnancy, okay. Otherwise, you can keep her for 6 hours and then again reassess her after 6 hours. If you find that there is still no expulsion of products of conception, you can proceed with manual vacuum aspiration. In second trimester, as per the regimen, 200 milligram of mifepristone, followed by 36 to 48 hours later, 800 microgram vaginal or sublingual misoprostol, followed by 400 microgram misoprostol, vaginal or sublingual,
every 4 hours, means up to 5 dosage. You wait for 3 hours after the last dose. And if it is failed, then you have to repeat the mifepristone dose of 200 milligram. Then you wait for 12 hours, followed by misoprostol 400 milligram, 5 dosages. So that means if the first attempt is failed, then you can go for second attempt again, even after 3 hours. Now, failure of medical management. So in case of failure of complete medical management, in cases of second trimester of MTP, we can try mechanical methods like Foley's catheter for cervical dilatation, followed by maybe escalating dose of oxytocin. But if it fails to dilate the cervix, the last resort will be hysterectomy. Now, failure of MPA procedure. There could be failure to dilate the cervix in cases of cervical stenosis, either due to previous surgeries like Fothergill's or due to infections. Now, misoprostol has come to our rescue, but sometimes if there is a fibrosis and we are doing a manual vacuum aspiration, we may find difficulty. In an anomalous uterus, if it is not known. In a angular pregnancy, because the pregnancy is sitting at one angle. Pregnancy of less than 6 weeks. Sometimes, as again Government of India guideline, this ultrasound is not mandatory and it's a very early pregnancy. And if we have done MVA, it can fail, and pregnancy of more than 12 weeks. Now, there could be cases of incomplete evacuation. So in cases of incomplete evacuation following medical management, if she is bleeding with RPOC, we can repeat tablet misoprostol 600 micrograms that can be given per vaginal or sublingual. And you have to look at the endometrial thickness of 20 millimeter or more post-medical management. And if there is a bleeding per vaginum, then again you have to go for MVA, that is manual vacuum aspiration. Now, continuation of pregnancy. We do get patients who have already consumed the drugs. The MTP was failed and they have continued the pregnancy. So in cases of continuation of pregnancy following MTP drugs can lead to serious conditions in the fetus. Mobius syndrome, that is palsy of the cranial nerves, that is 6th and 7th, is a rare disease and could happen because of the use of misoprostol during pregnancy, because they say that misoprostol contracts the uterus so much, and when the embryo is developing, even it can cause facial defects. There have been few cases reported of sirenomelia following mifepristone drug, and hence, in cases of failed MTP, evacuation is must, but sometimes the patient comes very late, which I have seen in my practice. Now, this is one of the study where they found that when the patient had consumed these drugs and continued the pregnancies, 7 weeks with mifepristone only given, they found sirenomelia. 8 weeks, 600, we are not using 600 of mifi anymore. Bilateral talipus with mifepristone. 9 weeks, again fingernail defects they found. 8 weeks talipus. 9 weeks again echeria and talipus. 7 to 8 weeks anencephalia, talipus, equinoris. 8 weeks again heart malformations, and 6 to 7 weeks one of the study cerebellum. So it cannot be left lightly. You will have to go into the history and see how much dosage she has taken, and a detailed anomaly scan will be required. Now, cesarean scar ectopic pregnancy, previous speakers have done an excellent job. And why I wanted to mention this, because you can think that it is a failed MTP. Because in public sector where the patients don't undergo previous scans, even if they are cases of previous LSCS, and they would have taken the drugs for medical abortion, the patient lands up with hemorrhage, which the another complication which I am going to talk about, hemorrhage, the hemorrhage, severe hemorrhage, a life-threatening hemorrhage can happen. And we think that it is a failed MTP. And we proceed with MVA, and we find that there is a torrential hemorrhage. I would like to share 2 cases where in one of the cases, I don't want to discuss the management, which has been already done very beautifully. One case, she had taken tablets outside. She came thinking that it is incomplete because it was showing some collection in the lower segment. We started patient bleeding, so bleeding profusely. We had to do a hysterectomy, public sector. Another patient, again, she came with bleeding. First day we did evacuation. The bleeding stopped. She settled. Once again, she came in a state of shock. We resuscitated her. Then we sent her for MRI. and we diagnosed scar pregnancy. And then we did a laparotomy and excision. So what I want to say, failed MTP can land up with severe hemorrhage. If there is a facility, it is always better to get ultrasound done to rule out this scar pregnancy, because also one of the cause of hemorrhage. Now, treatment options, I don't have to discuss about this. Now, coming to the complications. Complications, yes, hemorrhagic shock. The other complications will be dealt by Dr. Parag. There could be sepsis of the products, which can also lead to hemorrhage, perforation, and shock. Now, sequelae of complications these are the other sequelae, which I don't think late could be continuation of pregnancy, Asherman syndrome, and PID. So there is a patient with heavy vaginal bleeding and abdominal pain, comes back to the clinic in distress the day after a vacuum aspiration procedure was done. Okay, the diagnosis is incomplete abortion. How will you manage her if her clinical condition is stable? I think again, incomplete abortion, evacuation, Dr. Parak is going to talk about it. And if her clinical condition is not stable due to bleeding, then we have to really add. So what we have to do is we'll have to take a history, physical examination, investigations urgently required is definitely ABO-RH and hemoglobin. And we have to check whether there are products of conception felt in the cervical canal. We can easily do digital evacuation. Patient is unstable. We can just go with that. POC is not felt in the canal, then we'll have to establish the diagnosis with ultrasound. We will have to give her IV fluids, oxytocics, prostaglandins, antibiotics, and we'll have to proceed with vacuum aspiration as it is like an incomplete abortion and patient is bleeding. That is a stable patient. If the patient is unstable, she presents with heavy bright red vaginal bleeding, blood-soaked packs, there is a pallor, clinical assessment, resuscitation. I think as we do for any hemorrhage, immediately you will have to act. You will have to resuscitate the patient with big bore cannulas, IV fluids, investigations. All ABC need to be done immediately. You have to start the oxygen, start the IV fluids, and the patient may require blood transfusion. If she is in an unstable condition, even sometimes she can go in for DIC if she has bled so much. Okay. As we have seen the patients bleeding in some of the conditions, particularly the medical abortion patients, those who have taken the tablets across the counter, they'll end up in a public sector with these conditions. And so many times we have to really manage them. I just would like to share that we have applied anti-shock garment, we have arranged blood, and we have managed this hemorrhagic shock. And less than 5 grams, depending on her condition, we may have to decide that it is not only the PRBC, but we may have to go sometimes for massive blood transfusion, or we may have to give FFP and platelets. Okay, procedure after stabilizing the patient. If you find that there is a uterus atony, yes, oxytocics and aspiration, vacuum aspiration, visible cervical or vaginal laceration also could be there. In that case, we will have to give analgesics, pack the vagina, and shift her to OT for suture. Incomplete abortion, vacuum aspiration. Suspicion of intra-abdominal injury also can lead to hemorrhage. Perforation will be dealt by Dr. Parag. Yes, resuscitation and laparotomy may be required. If you are in a smaller place where you are not able to do, you may have to refer her for emergency laparotomy. Now, here is a patient, retroverted uterus, has an EVA procedure during which you note that the cannula passed a little further. This could be a perforation. Okay, so but there could be a bleeding per vagina is more than expected. So in cases of perforation also there could be more bleeding, but if you suspect perforation, then immediately we will have to see and manage accordingly, which the next speaker will deal with it. So I don't think I have to deal with that. After stabilizing the patient, you have to see that these are the signs which are again, I think, relevant to the perforation, which again, my next speaker is going to. Now, this is a patient who comes to you with a history of abortion procedure, done 5 days echo as a private clinic, unconscious state after bleeding heavily on the previous night. That's what I told you, that we do get cases like this in a condition of shock and presenting signs and symptoms. We can assess the shock index. we will find that the patient has bled depending on the shock index. For example, if her shock index is 1.2, already she has lost 30%. So all the signs of hemorrhagic shock will be there. We will have to investigate her accordingly, get her all the relevant investigations done, and stabilize the patient again with ABC, and she may require blood transfusion accordingly. After stabilizing, again, you have to wait. First, you will start the IV fluids. Meanwhile, you will arrange for the blood. You have to see that her blood pressure rises to more than 100, and you will have to also assess her mental status and the urinary output. Yes, oxygen should be on flow. You have to give a hemorrhage according to the whatever I have told and previously, that how we manage. And if there is a sepsis, need to be managed accordingly. So stabilize the patient. Now, one more reason I was told is undiagnosed ectopic cases in failed MTP, because we call it as a, so this also you have to keep in mind. Now, this happens when the patient repeatedly keeps on coming to you with pain and the bleeding. And if you do an ultrasound, you could have gone or proceeded with medical abortion because you could have found a pseudosac in the uterine cavity. So whenever we do an ultrasound, we should always look at the adnexa, because there are chances, because once we see something in the uterine cavity, we can miss the adnexa. So attention to gestational duration and the uterine size as related to the amount and the character of the evacuated tissue, particularly stating identification of villi and the fetal tissue, may help avoid this problem. Or on table, when you find you haven't got enough products, or the size of the uterus is not corresponding, or the sac of the size of the gestational sac is not corresponding. Now you have different levels. Why I have taken this? Because these are all there in Government of India guidelines. Management options at different levels of facilities, because we have trained medical officers who can use medical abortions. They can give medical abortions for the patients in first trimester. So they have to initially do the clinical assessment of the women coming with abortion complications, resuscitation, stabilization treatment, including antibiotic therapy, IV fluids, oxytocics, and prostaglandin, and diagnosis of the type of abortion complication. They should investigate her and prepare for definitive treatment, or refer to an appropriate facility for further management and care, or they can proceed with vacuum aspiration if they think that it was incomplete. At secondary and tertiary level, all services provided at the primary level, plus they should have the facility for the blood cross matching and transfusion, ultrasound, X-ray abdomen, and other relevant investigation. Laparotomy and indicated surgery, if required, the facilities are there in these places, and the treatment of severe complications also need to be managed. So the patient have to be shifted to tertiary level, and she may also require treatment of DIC if she had a severe hemorrhage. So hemorrhage, even in MTP, cannot be taken easily, because we do find patients coming to us with a very unstable condition and requiring multiple transfusions. So the prognosis of these patients is generally good with a proper workup, close obstetric follow-up, and patient education. What is important is patient education. So failed abortions are most commonly treated expectantly with frequent obstetricians follow-up and serial quantitative beta-HCG levels. And most of these women will expel the fragments of conception on their own without the need for further medical or surgical treatment. So as it is a short presentation, I was able to cover this much. So thank you very much for your patient hearing.
Excellent, Dr. Sheila. And please answer queries in the chat box. Yeah, Richa, let's invite Dr. Parag. Yeah.
So now we move on to the next topic, that is perforation and retained product of conception. Diagnosis and management by Dr. Parag Biniwale, sir. I think everybody know all ICOGs, FOGSIans. We all know who Dr. Parag Biniwale, sir, is. And he was a past secretary of ICOG, all of us know, and currently he is the president of Pune Obs and Gynae Society and vice chairperson of ICOG.
Thank you, Richa.
So
thank you so
we welcome
much.
you, sir.
Thank you. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to have a dialogue with all of you on this very important subject of abortion. So at the outset, let me thank Dr. Lakshmi Shri Khande, the chairperson, and of course, Dr. Richa Sharma, who's the chairperson of Medical Disorder MTB Committee of FOGSI. Thank you, Richa and Kruti, for the invite. In next 12 minutes, I'm going to try and finish two important aspects, that is uterine perforation and retained products of conception. Dr. Sheila has made a wonderful presentation and she has made a background very, very clear. So when we talk about uterine perforation, it's not a common occurrence these days. I think it's all thanks to the medicated abortion, which all of us are doing for last almost 20 years. And of course, the MVA, which is definitely a boon when we think of perforation. So in last 20 years, barring one or two cases, we've not faced any cases of perforation. And the frequency of possibility of perforation increases if the gestational age is advanced, and of course, the provider is inexperienced. So nowadays, it is seen in very, very rare situation, 0.1 to 3 per 1,000 induced abortion procedures. And it is more commonly seen in women who have certain risk factors. So these risk factors would include uterine position, also an acutely retroverted or acutely anteverted uterus makes it prone, multiple gestation, advanced gestational age. If the dilatation is difficult, it is likely that we may perforate the uterus. And of course, previous cervical and uterine surgery would add misery to the complication of perforation. So it is really important that we diagnose it. So typically there would be a loss of resistance, there would be a drop in pressure in MVA syringe, passage of an instrument well beyond the expected length of the uterus, and of course, bleeding. So it is really important that we counsel our patients right from the beginning of the procedure. So possibly women who are at risk of having perforation, we should talk to them that there is a very small chance of uterine perforation when we are attempting the surgical procedure. We should also tell them what are the actions that may be required when we do these procedures. And of course, if at all there is a rare situation of complication of perforation, then what are the treatment options? So it is really important that the surgeon is vigilant, because uterine perforation can occur at any step of abortion process. So it could be dilatation, it could be a cannula which can perforate, or even in good old days when we used to do curettage of the uterus. So that was probably the commonest reason why the uteri perforated. So the location of the perforation can be anywhere in the uterus. It can be in the middle segment or anterior, posterior, and fundus is something which is rather more common. And uterine perforation often goes undetected, especially in the early first trimester, but generally less than 13 weeks, perforation is supposed to be less common as compared to pregnancies which are beyond 13 weeks. So you're doing a procedure and you're suspecting that the perforation has taken place. So don't panic, stop the procedure. Please note that there is no role of uterotonics. So don't pump in pitocin, don't pump in methyl argometrin or even prostadine. If available, ultrasound is many a times a helpful diagnostic aid. It may not diagnose the perforation, but it will at least tell you whether the procedure is complete or not. The provider does not need to definitively diagnose a perforation if the patient is stable. So if you are thinking that there is a less chance of intra-abdominal injury, don't worry. Counsel the relatives that there is a possibility of perforation. Keep the patient admitted for 24 hours and monitor her very, very carefully. So it is really important that we monitor these women carefully, make sure if she's unstable, stabilize with IV fluids, antibiotics may be offered, if needed, administration of oxygen is important. It is really important that we ensure that the procedure is complete, because these are the women who would otherwise keep on bleeding. So if the abortion was not completed, the uterus may be evacuated under direct visualization at the time of laparoscopy or laparotomy if you decide to do so. There is no evidence available to support the safety or efficacy of medical management to complete uterine evacuation immediately following suspected or confirmed uterine perforation. So the management will totally depend on the site of perforation, completeness of procedure, gestational age, damage to the adjacent organ, ongoing bleeding, and hematoma formation. So if you are suspecting that there is a possible injury to intra-abdominal organs, we should put in a laparoscope, or very rarely we may have to even open up the patient to look at the possible perforation. If there is a small uterine perforation which is bleeding, then we may think of cauterizing or take a suture and control the situation. If you are able to see the yellow fatty tissue, then you have to understand that you have probably injured the bladder. So immediately a surgical team has to be called in. They should examine the abdomen. If needed, laparotomy may be required. So prompt recognition and management of injury to abdominopelvic viscera is really important in order to avoid serious complications. So if you are suspecting a bowel injury, call in a surgeon, have a look at the abdomen through a laparoscope with obvious bowel damage or herniation through the uterine defect, excessive bleeding, or hemodynamic instability. Immediate laparotomy may be preferable, but you must know your limitations. If your hospital, if your setup is not geared up in managing such situations, please feel free to shift the patient to a tertiary care center, because the patient should receive best possible care and it shouldn't endanger her life. So it is really important to shift the patient at the right time. So women at risk of shock require IV line, supplementing with oxygen. Fluid resuscitation is important, and one may have to think of replacing blood if there is a lot of blood loss. And please be prepared for medico-legal issues, because the factors which will save you probably would be counseling, good communication with the patient and the relatives, pre-procedure, intra-procedure, and after procedure. Please document everything that has taken place. So the communication has to be documented. The operation notes should be perfectly written about the possible injury and the actions that you as the healthcare provider have taken, and of course, take help of medico-legal expert. The second part is incomplete abortion. And when we say there is incomplete abortion, we just have to examine the patient, see the general condition. If the general condition is stable, go ahead with the further management. If she's unstable, resuscitate, stabilize her, and then examine her in detail. Now, there is a possibility that while examination, when you put in a speculum, you may feel the products at the cervical os. So one can think of doing a manual digital evacuation, or even a vacuum forceps. And of course, vacuum aspiration is needed in these women. But if you're not able to see the products at the os and you're suspecting that there are still some products inside, then ultrasound will be of great help. And of course, then we can think of offering a dose of misoprostol, either vaginally or buccally or sublingually, if the ultrasound suggests that there is incomplete abortion. If the bleeding continues even after an additional dose of misoprostol, vacuum aspiration is something which is really important. And this is one important chart which all of us must remember, because whenever we are suspecting incomplete abortion, generally these women will come with excessive bleeding or continuous bleeding. There may be pain or there may not be pain. If she's unstable, resuscitate her, check her vitals, airway, oxygen is important. Give her IV fluids with 18G cannula. Dr. Sheila has already talked about it. Oxytocin may be administered to these women, especially if the uterine size is more than 14 weeks. Antibiotics are important, and blood transfusion is may be required. So if the condition is stable, go ahead with either digital evacuation or think of doing an ultrasound if you are not able to clinically notice the incompleteness of abortion. So do an ultrasound, and depending on the report of ultrasound, we need to discuss with the patient and take a call as to whether this patient can be managed medically or with vacuum aspiration. And please don't forget to offer her contraception, because this is going to prevent a lot of miseries. This is going to prevent a lot of unwanted pregnancies and issues related to completeness of the abortion procedure. So these are some of the important points that we remember. We need to have good care while performing surgical evacuation as a part of MTP. MVA is the thing which is so important, and I must compliment the MTP committee, because this is the committee which 20 years ago started training with MVA, and this is something which is the norm these days. Experienced service provider should perform the procedure, especially in difficult situations. Oral abortifacients have definitely reduced the incidence of these dreaded complications. So please offer medical methods, counsel the woman, ask her to make a choice. Let's try and reduce surgical procedures when we have such an excellent medicated abortion available to our kitty. And service providers should take utmost precautions, as uterine perforation can lead to severe morbidity, mortality, and even long-term sequelae. Thank you very much. So once again, thank you, Richa, and thank you, Dr. Lakshmi, for an invitation. Thank you.
Thank you, sir, for a very comprehensive talk, and you finished on time and you were to the point. Thank you so much.
Thank you.
So now we go on to our last topic. That is very important topic. That is how consent taking in the special categories by Dr. MC Patel, sir. So now can I request the chairpersons to introduce Dr. MC Patel, sir? Sir has joined?
Can't see him.
I think.
Yes, ma'am. Sir has joined. Sir has joined. I confirm.
Yeah.
So I will introduce Dr. MC Patel, sir. It's always an honor.
Yeah, he is already co-host. Sir, please, meantime, you start your screen sharing. Yeah. MC Patel, sir. Yeah.
Yeah, it's always an honor to introduce Dr. MC Patel, sir, a very well-known medical legal advisor, Vice President, FOGSI 2016, Organizing Secretary, ICOG 2017, Honorable Member, National Inspection and Monitoring Committee, PNDT Act, Government of India. He will deliver a lecture, How to Take a Consent in Case of Medical and Surgical Abortion. Dr. MC Patel, sir, please. Dr. MC Patel, sir.
We can't hear you. We can see your screen. Unmute करो मिताली.
तो मैम कोर्स ही किया है, उनको पहले से किया है.
ठीक है सर, किस नाम से लॉगिन हुए हैं पता नहीं.
Yes, sir is there. We can
Yes.
see the screen also.
So,
Yes, sir. Welcome, sir.
Okay. So thank you, Dr. Sangeeta, for kind words, and straightway to the subject. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. Just now I am hearing Dr. Parag about complication of MTP. You won't believe that 2 to 3 calls in a week I received from all over India, from our FOGSian friends, and they are related to such problem. Even yesterday only, I had a phone call from Hyderabad. There was a case of MTP. It was perforation. It was injury to bowel. Of course, it was detected well in time. Laparotomy was done. Colostomy was done. Patient is saved. But now she was worried that if at all litigation happens, what steps she should take. I advise accordingly. But it is very common in our day-to-day practice. So before I go to the subject, I would like to thank ICOG Chair Dr. Lakshmi Srikhande and MTP Committee Chair Dr. Richa Sharma for inviting me to share my views about the subject, and of course Dr. Kruti Deliwala also. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly, and steadily, and unluckily we gynecologists rank first. So that is why this type of subject we have to go for discussion. This is very famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. And consent is not mere just sign here. It is more than that. And in this very case, it was discussed and decided at length what should be the ideal consent and which are the criteria for any consent to be valid in Indian context. So concept of consent in India and what is valid consent. Let us see first, and then we will switch over to the consent for MTP. So which are the criteria for any consent to be valid? First criteria is capacity or competence. Any adult and mentally sound patient can give consent for herself, for any surgery, for any procedure, for MTP also. So when patient is major, when patient is mentally sound, only and only patient can give consent. So consent given by any other person is not valid in eye of law. Can minor give consent for examination? Yes, if she is more than 12 years, then she can give consent for examination. See, if it is a case of sexual assault and patient is brought to you, when patient is more than 12 years, she can give consent for examination. But if at all, if it is a case of pregnancy and pregnancy is to be terminated, then can she give consent for surgery or procedure? No, she cannot give consent for that. And in this situation, when patient is minor, consent of guardian is very much required. So if it is a case of termination of pregnancy, then consent of guardian is required in case of minor. If she is mentally challenged, can she give consent for termination of pregnancy? Again, no. Again, consent of guardian is required in this type of situation. So it is very clear, when patient is minor, when patient is mentally challenged, consent of guardian is very much needed. If patient is visually challenged and if patient is major and visually challenged and patient is for termination of pregnancy, can she give consent? Yes, if she is visually challenged, but if she is major, if she is mentally sound, and if we can communicate her, if we can listen her, if we can understand our conversation, then she can give consent even if she is visually challenged. But in this type of situation, there are two situations. Can she sign? Yes, of course. If she can sign, then you can have a signature on consent paper. But again, there will be the question, whatever written in consent form, we have to explain everything to the patient. But we usually do not allow any witness in consent in MTP cases. But here, there is special case. So we will have to invite one witness who will sign the consent, that whatever written in this consent paper was explained to this patient before me and she has signed before me. If she is unable to sign and she is visually challenged, then consent of any of her guardian will be required in this type of situation. Consent should be voluntary. Whenever you are going to go for consent for termination of pregnancy, it should be voluntary and it should be free, signed by patient or guardian as per the case may be, and others are witnesses only. But in usual course, in normal patient, we do not go for signature of witness because it is a confidential matter. But in special cases, in case of guardian or so, we have to go for. Consent should be informed one. So are your patient properly informed is very much important. So termination of pregnancy consent is very much required. In case of any complication, intraoperative and postoperative counseling and consent is also equally important. Patient should have knowledge about nature of treatment which method we are going to go for termination of pregnancy with all its benefits and side effects and its limitation. No fraud, no coercion, no false promise. So consent should be informed one. We should explain all the available alternative of termination of pregnancy to the patient, and patient may choose any option she is comfortable. Of course, we can explain which is suitable option for her with all its benefits, but ultimate decision will be on part of patient. One more question many times asked at the time of taking consent. Does Supreme Court expect us to talk about all possible complications? So in this case of Samira Kohli versus Prabha Manchanda, court has very specifically mentioned that one should anticipate certain complications or requirement depending upon the condition of the patient. And we have to explain all the probable complications. But at the same time, court has very specifically mentioned that no need to explain remote or theoretical risk involved, which may frighten or confuse the patient and result in refusal of the consent for necessary treatment. As far as anesthesia is concerned, if you are going to go for surgical method and if anesthesia is required, then separate consent for anesthesia is required with all the points related to nature, benefit, purpose, effects, alternative, and substantial risk involved in anesthesia. An anesthesiologist is the best person to explain everything and consent to be taken for anesthesia separately. If at all there is a need of blood transfusion or blood product transfusion, before that was a procedure or after procedure due to some complication, then separate consent for blood transfusion is very much required. And again, we have to explain about purpose, effect, alternative, and substantial risk involved in blood transfusion. Does consent required for blood transfusion is a question. So in this case, National Commission has very specifically mentioned that doctor is required to get two separate consent from the patient, one for surgery or procedure and another for blood transfusion if anticipated, because surgery involves risk and blood transfusion involves additional risk. So separate consent for blood or blood product transfusion is required. Refusal of treatment. Many times patient may refuse to give consent. So in this type of situation, when patient refuses to go for consent, then need to explain risk of refusal of treatment. It was suggested by Supreme Court in that very famous case of Samira Kohli versus Prabha Manchanda. But at the same time, Supreme Court has very specifically mentioned no need to explain remote or theoretical risk of refusal of treatment, which may persuade the patient to undergo a fanciful or unnecessary treatment. So balance should be achieved at the time of counseling the patient for termination of pregnancy. One more question. There can be a common consent for particular surgical procedure and additional or further procedure. Say, for example, termination of pregnancy with insertion of IUCD, termination of pregnancy with abdominal, tubal ligation, sterilization operation. So we can go with a common consent for both the condition. Consent given for specific treatment cannot do other procedure unless life-saving. Argument that it was beneficial, would save time, would save pain and suffering in future doesn't stand in court of law. Say, for example, at the time of termination of pregnancy, if you find that next pregnancy could be dangerous for patient, unless consent is taken for this female sterilization operation, you cannot go for female sterilization operation because prior consent is very much required, because it is not immediate risk to the life of patient. Patient is not going to be pregnant next day only. So unless consent is taken for female sterilization operation, you cannot go for sterilization operation with termination of pregnancy. One more area. Is written consent mandatory? For any surgery, as per law, there are 3 conditions where written consent is very much mandatory. One is organ transplantation, sonography in case of obstetric sonography in under PCPNDT Act, and any case of termination of pregnancy where written consent is very much mandatory. So in this case, we have to go for written consent only, and burden of proof is on shoulder of doctor. So we have to explain everything, and then written consent is to be taken. Consent can be taken by assistant doctor, but it is for other surgery, not for termination of pregnancy, because as far as termination of pregnancy is concerned, all the confidential data you have received from the patient during history taking and during examination, you cannot share with anybody without permission of patient. So in this type of situation, consent should be taken by doctor himself who is going to terminate pregnancy. Otherwise, in other surgery, consent can be taken by assistant doctor. Also, can it be taken on pre-printed form? Yes, but there was case recently happened with RG Stone Hospital versus Vinod Khanna. In this, patient was HIV positive, and he was needed some urological surgery. He was wandering from one hospital to another hospital, but when he was HIV positive, hospital were refusing. Only RG Stone Hospital took that patient. Surgery was done. Everything was fine. Post-operative event was uneventful. Patient was discharged, but patient filed a complaint that consent was taken on pre-printed form, and compensation of ₹10 lakhs was awarded to the patient. Because in this case, at the time of deciding this case in National Commission has very specifically mentioned that there was no negligence on part of a treating doctor. But when consent was taken on pre-printed form, so it becomes an unfair trade practice. But this judgment is challenged in higher fora, and at the time of allowing this appeal in higher fora, there was discussion about word unfair trade practice. What is unfair trade practice? Any means you go to enhance your business is an unfair means of trade practice. But as far as our practice is concerned, whether we take signature on pre-printed form or whether we take signature on consent which is written by patient herself or written by surgeon who is going to operate the patient, does it make any difference as far as enhancement of business is concerned? I don't think in medical practice it may have any effect. So this argument was taken into consideration by higher fora, and case is filed as far as appeal is concerned, and stay is granted. So that judgment is stayed till further judgment comes. So we can use pre-printed form very well in our practice. And we are quite confident that in this appeal, we will win the case. And as far as our medical fraternity is concerned, pre-printed form, even today we can use, and in future we will be able to use. Should it be in English or in vernacular language? It is always better to be in vernacular language. But if at all it is in English, then at the end of consent, patient should write in her own handwriting whatever written above was explained to me in language which I could understand. And after understanding everything, and after I have some question or query, they were answered by doctor, and then only I have signed the consent. So if it is like this, then consent in English can also be taken. Who should sign consent? Just I mentioned patient and doctor. So consent in case of MTP. As per MTP Act 1971, consent is very much mandatory to be taken on Form C only. But here in Form C, it is written like this only: I give my consent to terminate my pregnancy. So it is not informed consent. So we have to take consent in Form C. It is very much mandatory. But again, we will have to go for informed consent. So we will have to go for two consent. one informed C and one informed consent. As far as patient, if it is minor or mentally retarded, then consent of guardian is to be taken. This is part 2 of Form C. It is prescribed form as per MTP Act 1971, and it is very much mandatory. If you have not taken consent in Form C and if you have terminated pregnancy, it is all likely that you may be tried under Section 313 of Indian Penal Code, and there is a provision of imprisonment of 10 years and fine or both, and one cannot afford this punishment. So it is very much mandatory to take consent in Form C. But instead of Form C, can one take consent in usual manner as it is taken in other surgery? No, you can take informed consent, but consent to be taken in Form C is very much mandatory. Consent taken in any other form cannot replace consent to be taken in Form C. But you have not to remember, you have not to worry anything. You have to simply visit FOGSI website, and FOGSI uniform consents are available. We 3 medical legal counselor, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent. And in those list of consent for termination of pregnancy is also there. So medical method or surgical method, consent is very much available on FOGSI website. You can download and you can utilize in your day-to-day practice. As far as consent is concerned, we have prepared all those consent in 2 forms. Part 1 is information, and we have taken all the criteria into consideration which were discussed in Supreme Court in 2008 at the time of deciding case of Samira Kohli versus Prabha Manchanda. So it is like this: name of procedure. Say for example, medical termination of pregnancy by medical method. Meaning, what is the meaning of termination of pregnancy by medical method? And we have mentioned everything in a very simple language. Purpose or indication. Which are the indications available as per MTP Act? We have mentioned that you have to strictly mark the indication which is fit in your patient. Description of the procedure, how this medical method will act as far as termination of pregnancy is concerned. Benefit of procedure, which are the benefit with this medical method. Alternatives, we have mentioned all the alternative to medical method also. Consequences of refusal of procedure. If patient refuses to give consent, then which are the consequences? We have mentioned that also. Outline the substantial risk, excessive or prolonged bleeding, pain, may need surgical procedure, possibility of infection, possibility of incomplete evacuation or failure of termination of pregnancy. Every individual has a different way to cope up. We have mentioned that also. And part 2 is undertaking. So whatever we have mentioned in part 1 about information, patient will go for undertaking in part 2. But very important point we have mentioned in part 2 is, I understand that during course of treatment, doctor may find other unanticipated unhealthy condition that may need specific action, procedure, surgery, or anesthesia. If doctor feels that it will be beneficial to treat such condition, and if I am not in a mental or physical capacity to give consent, doctor may take necessary decision after discussing with Mr. or Mrs. So-and-so who is waiting outside operation theater. I authorize above mentioned person to give proxy consent on my behalf. So if at all some emergency happens during termination of pregnancy by medical method or surgical method, patient is not in a position to give consent, and if patient has given you a consent like this, you can discuss with that person and you can take decision accordingly. We have mentioned this type of also. In order to save life, it may even be necessary to do additional surgery or procedure and prolong anesthesia, which are beyond scope of consent given by me. I authorize doctor to take such decision if need be. So if patient has given consent like this, then you can very well proceed beyond scope of consent given by patient. And at the end of consent, signature or thumb impression of patient But if at all it is thumb impression, then thumb impression should be well attested by a person who knows the patient. But again, in this condition, it is a breach of confidentiality. So we should explain everything to the patient. And if patient allows that fellow who will attest this thumb impression, then it will be pardoned, and signature of doctor is very much must. MTP with tubal ligation. So prior consent is very much required in case of MTP with tubal ligation. So you should have facility to go for tubal ligation surgery with MTP, because tubal ligation is a national program. So if at all any complications happen, even if it is related to MTP, then also there could be a special inquiry. So you should have all the facility to deal with the situation accordingly, and you should be experienced person to deal with the situation, and prior consent is very much must. And in this famous case of C. Jaipal Reddy versus Padmini Veluri, it was very specifically mentioned by National Commission that consent is not a mere piece of paper where patient or relative has to merely sign the consent paper, but it is a very important document of your counseling, important document of your communication. So whatever you have counseled, whatever you have communicated to the patient about your treatment plan, medical or surgical, as far as termination of pregnancy is concerned, you have to explain everything, you have to mention everything in your consent paper, and at the end of that consent, patient has to sign. And once patient signs that document, it becomes a documentation of your communication. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many provisions in MTP Act in your favor, but if you do not know how to use those provisions in your favor, it won't be useful in your favor. So have some basic legal knowledge, always obtain medical legal advice whenever you are in doubt. There is always a way. So if you want to sleep like this, take tender care of your patient, comply with the provision of MTP Act, and pray our Almighty God before going to sleep, and keep my visiting card below your pillow. And this is a very interesting video. This gentleman is going upstairs and some people wants to help him. Let us see how they help him. Only 1 or 2 minutes. Actually, that gentleman had to go upstairs. So even if you want to help somebody, then also you have to explain and you have to take consent. So with regards, salute to organizers, again, Dr. Lakshmi Srikhande, Chairperson ICOG, Dr. Richa Sharma, Chairperson MTP Committee, and Dr. Kruti for inviting me to share my views about the subject. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much.
Fantastic talk, sir, as usual. And you have clarified all the things as far as written informed consent is concerned. So thank you once again on behalf of ICOG, and please answer all the queries in the chat box. And in the meantime, we will go ahead with the post test, Richa.
Yes.
Yeah, so dear
Thank
delegates.
you, MC Patel, sir, for a very crisp and informative talk, sir. Thank you. So now can we share the link for a post test now?
Yes, Mitali, please post the link. So we are starting with the post test. See your chat box. The link will be there. Click on it and start giving post test. Time given is 10 minutes. We are starting the timer as well. Yeah, it has been started. And we all will be on the silent mode so that there won't be any audio for 10 minutes.
Dr. Lakshmi,
Yes, sir.
there are so many questions in chat box.
Yeah.
And to reply in writing is very difficult. So after this post test, if you permit or if time is there, I can very quickly answer all the queries.
Okay, I think Alka was there, sir. She has answered many queries, but remaining queries, I think during post.
Oh, yes. After post test,
Yeah,
if at all time permits.
Yeah, Richa, quickly you can ask the questions and sir will answer. Yeah.
Majority, I think me and Dr. Alka has already answered.
No
Yeah.
issue. Then
I
it's
will put
fine.
up
It's fine.
only.
It's fine.
Those questions which are still unanswered,
Because
that I
I
will just
saw
pick up.
long list of all the questions.
either you can answer in the chat box because that will really save time, Richa. Yeah. And who is sharing the answers after this post test?
Yeah. Kruti, be ready with the your slides.
Yeah. Meantime, teacher, you can start answering as many as you can. And if there are few remaining for sir, then you can ask him.
આ બાજુમાં બૂમો પાડે છે ધન્વીની.
Kruti, stop sharing your screen. Kruti.
Dr. Kruti, you don't share the screen now.
Because all the
it is
answers are
visible.
Don't share. Yeah. Great. Happy to see that so many have already submitted. 1 minute left. So time is up. Richa, either your today's post test is easy or all the delegates who attempted, they're really alert and attentive. So Kruti, please show the answers. Yeah.
Can we discuss, ma'am? Can Dr.
Yeah,
Patel?
yeah, please just discuss.
Just, I think two
Yeah.
questions. I think sir will answer. They want to know, one is that along with Form C for MTP, so FOGSI focus consent, is it necessary to fill? Your FOGSI focus is there, na, sir? All the consent forms, additional everything. So they are asking along with C, do we have
Not
to fill that
necessarily
also?
mandatory, because it is only informed consent. Because in Form C, there is not informed consent. In Form C, she only writes, I am ready to terminate, get my pregnancy terminated. So informed consent is very much required, because if at all something goes wrong and litigation happens, then it becomes very difficult for anybody to face. So informed consent with Form C is very much required.
So they should keep a copy of it, all the those forms along with C form.
Yes,
all the things should be signed. So that is a one important message for all the audience. And another one they want to ask, that is a gynecologist DGO. They want to do the tubal ligation and they are from the district hospital. So do they need any extra certificate from district hospital?
No, if they are registered with respective medical council of state, in private, they can very well go with tubal ligation, even left tubal ligation, no issue. But if at all they want their hospital to be en panel with government for benefit of this ICIC Lombard, there is a what we say, in case of any complication or in case of failure or in case of death, compensation is awarded by this ICIC Lombard if your hospital is M-panel with government for that. So for that, you will have to require to be M-panel, and for that permission from government will be required. Otherwise, in private, it is not required.
Okay, and the government setup, this will be covered under family planning.
Government setup, it is system. And if there is a protocol as per government setup, they can do, then they can do. Otherwise, they will to go for special training and empanelment in the panel of surgeon.
Is it different family planning indemnity scheme? What is being followed, sir?
Yes.
So is it different for private hospitals and government hospitals?
It is a collaboration with government and ICIC Lombard company. And there are very specific criteria in that. Say, for example, if it is a complication, then 25,000 will be awarded. If it is a failure, then some 50,000 will be awarded. If it is a death within less than 30 days of surgery, then 2 lakhs will be awarded. So that way there is a table of all the compensation. So if any private hospital is en panel with government for that benefit, then anything happens in that particular hospital as far as this tubal ligation part is concerned, then that benefit will be available to the relative of the patient or patient.
Okay, so take home for this is that they don't need any special training, DGO doctors, and they have to be impaneled, and their center or the hospital has to be impaneled. That's all. Now, last one question. One patient, Shweta, is asking persistent vegetative state after hanging with 16 weeks live pregnancy. In-laws want pregnancy, kindly opine. I'm not able to understand what is the
age of patient. What is the age of
They
patient?
have not written, just a period
No
of
issue. Chalo, I will answer. If she
Yeah.
is major, then with consent of guardian, pregnancy can be terminated. If she is minor, of course, pregnancy can be terminated, but police is to be informed and product of conception is to be preserved in saline and it is to be handed over to the police.
They have not specified they want MTP. In-laws want pregnancy. So whether they want to continue or whether
They want to continue or termination.
Yeah.
Continue. So
I think that's all, sir. I think other things are covered.
to continue pregnancy is a different area.
Yes.
If at all there is termination of pregnancy, then I have specified.
Thank you, sir. Thank you.
Thank you so much, MC Patel, sir. Kruti, now please show the answers. Yeah.
Yes, ma'am. Thank you so much, sir. For question 1, the answer is C, that is 7 mm.
Can you zoom it? We are not able to see the screen.
Yes, yes, ma'am.
Increase the this thing, zoom size.
Let it be, because I think she has already taken her husband's help. So yes, we can see. Kruti, please go ahead. Yeah.
Yes, ma'am. For question 1, the answer is C, that is 7 mm. For question 2, the answer is also C, that is 16 to 24 mm gestational sac and no embryo. For question 3, the answer is C, that is nuchal translucency. For question 4, the answer is B, that is karyotype, structural check, and decide accordingly.
Okay, next.
Just press arrow button on your laptop.
Yes, ma'am.
Yes, great. Correct.
For question 5, the answer is D, that is all of the above. For question 6, the answer is D, that is mid-sagittal view. For question 7, the answer is C, that is 10 to 14 weeks. For question 8, the answer is A, cannot be measured in the prone position of the fetus as long as the FMF criteria are fulfilled. That is the criteria for measuring the NT. For question 9, the answer is D, all of the above. For question 10, the answer is C, 10 to 13 weeks. For question 11, the answer is A, that is lower rates of the cesarean section for the fetal distress in labor. For question 12, the answer is C, that is presence of the ductus venosus blood flow. For question 13, the answer is D, that is renal cyst. For question 14, the answer is C, that is HPL. For question 15, the answer is D, that is not willing for the invasive test like the CVS and amniocentesis. For question 16, the answer is A, that is 10 weeks. For question 17, the answer is C, severity of the diabetes mellitus. For question 18, the answer is C, that is either of the above. For question 19, the answer is B, 69XXX. For question 20, the answer is A, that is trophoblast is delivered from the outer cell mass of the pre-implantation of the embryo. For question 21, the answer is B, the method of evacuation is by the hysterotomy when the size is more than 20 weeks. For question 22, the answer is C, that is 1500 milli international unit per ml. For question 23, the answer is C, E, that is complex adnexal mass. For question 24, the answer is D, that is ovarian. For question 25, the answer is B, that is 15%. For question 26, the answer is B, that is 2 to 5%. For question 27, the answer is C, that is presence of the cardiac activity. For question 28, the answer is A, that is vacuum aspiration. For question 29, the answer is A, That is, hemorrhage is due to the retained products. For question 30, again the answer is A. Laparotomy is required when there is suspicion of the uterine perforation. That's all. Thank you, ma'am.
Great, great. You can stop screen sharing. So now everyone knows how many marks they have scored. So yes, Richa, if you want to sum up, and today we will be meeting again at sharp 4. Yes, Richa.
Yes. So now today we learned all sorts of abortions, ectopics, molar, and then also we learned about the first and second trimester and anomalies, how to pick up prenatal diagnosis. Now tomorrow it is a very important session we have, that is a medical legalities or the litigations. So tomorrow we'll be covering about the mob violence, intimate partner violence, then also death on table, how to tackle, and then very interesting panel on MTP litigations, that is a case-based discussion. And then rape victim, how to examine. So I request all of you to join tomorrow again, and sharp at 4 o'clock we will be starting. And thank you so much. Now majority of the people, I think they have missed the pre-test, so I request don't worry about it, just concentrate on the post-test, but you will get the certificate if you have answered all 3 post-tests of all 3 days and secured 50% marks. So
and those you all can pass on this link to your friends, because not everyone is interested in the certificate. So those who are interested in just learning, because tomorrow is very, very important module that is on litigation. So those who are interested in learning and not in the certificate are also welcome to log in and learn from all the experts. That is tomorrow, day 3 module.
So with this, I think we wind up.
Yes.
And thank you so much, all the participants. And thank you all the faculty, chairpersons, speakers for the informative sessions. And thank you, Lakshmi Madam, for all the encouragement. And thank you, Kruti, for being there. And thank you, ICOG office and Nilima, Kanchan, everybody who are at the back side and helping us in each and everything. So thank you so much. And so now we close the session.
Yes.
Thank
Good
you
night.
so much, ma'am. Thank you, Lakshmi ma'am, and thank you, Richa ma'am. Thank you so much. And all the office staff for helping the things. Thank you, ma'am. And all the chairpersons and every speakers and faculties and delegates too. Thank you so much.
Thank you.
Thank you all. Good night.
Good night.
Please stop recording and you can end the meeting. So see you all tomorrow at sharp 4 p.m. Yeah.
Thank you, ma'am.